because it's like a little bit noisy. I will close the window. I don't have a mic or something, so yeah, it's fine? Yeah? Okay. Yeah. Maybe you can give me a sign if I have to speak louder. Yeah? What's the sign?
Yes.
Okay.
Something with the ears.
So I don't know when I have to start.
Yeah, let's start with you.
Oh, if I'm ready, then he...
Yeah, he's ready.
Okay. I was waiting for the tape. Okay, let's start. Welcome, everyone, to this International Working Conference on Maternity Care Systems, supported by the Dutch Research Council. A warm thank you to all our guests online joining us, and to those who have traveled from abroad or from within the Netherlands. We are delighted to have you here with us. And then I have a problem. It's not working at all. We just checked it and yes, thank you. I'm sorry. My name is Esther Feyenoord. I'm an associate professor in midwifery science, a health scientist and a midwife. Since 2008, I've been doing research in midwifery science, focusing mainly on how maternity care is organized. My particular interest is improving access to care for pregnant individuals, while at the same time ensuring a healthy workforce. After all, we know that high-quality care can only happen when healthcare professionals are healthy and happy in their work. Together with my colleague, Lisbeth Kool, she's sitting over here, I developed the plan for this open meeting, which is aimed at both national and international maternity care professionals. The plan grew from the challenges we faced when trying to apply scientific knowledge from other countries to Dutch research. To make this happen, we wrote a grant proposal to the Dutch Research Council, and it was approved. Thanks to this grant, we can now host this meeting online for our audience and on-site for our presenters. So, where are we? Thank you. Here you can see the map of Europe and the Netherlands. We are in Groningen, in the north of the Netherlands. For those joining us on site, we are at Hotel Halbert, a beautiful building that dates back to the 17th century. And just for a bit of history, the city of Groningen itself was founded almost 1,000 years ago in the year 1040. Before we dive into the presentations and discussions, I'd like us to take a moment to reflect. One of the biggest challenges in international midwifery research is understanding the context in which care is provided. We often read studies from other countries and try applying their findings to our systems. But we risk misunderstanding the results if we don't fully understand how those systems work. So what do we really know about midwifery abroad? This isn't just a challenge for researchers. It also matters for educators, policymakers and practicing midwives. If we want to improve midwifery care globally, we need to understand each other's systems. I'll show you 3 questions to help us think more critically about this. They look similar at first, but each one goes a little bit deeper. These questions are not just academic. They have real consequences for care. So let's take a moment to explore them together. The first question seems simple. What do I truly know about how midwifery care is organized in other countries? We often think we understand the basics, but in reality, maternity care systems can differ enormously in their structure, in how they're funded, in who carries which responsibilities, and even in their underlying philosophy. The second question goes a little deeper. How might my assumptions about midwifery systems influence the way I interpret international research? When we read a study through the lens of our own system, we might misjudge its relevance or applicability. What seems logical or effective in one country may not work in the same way in another. Similar systems on paper can operate in completely different ways in practice. If we don't question our assumptions, we risk drawing the wrong conclusions and making decisions that don't fit our reality. So, as we move forward today, let's keep asking, what assumptions am I bringing to the table and how might they shape the way I see the evidence? Finally, the third question. What risks do we face when we apply research findings without fully understanding the context in which they were generated? This is where things get critical. Using research without considering its context can lead to ineffective policies, poor clinical decisions, and even harm. That's why this open science meeting matters, to build mutual understanding and make sure international research is applied with care and accuracy. What looks similar on paper can be very different in practice. If we overlook those differences, we risk drawing the wrong conclusions and making decisions that don't fit our reality. In fact, this realization planted the seed for today's meeting. We need spaces like this to share knowledge, challenge assumptions, and make sure the research truly improves care without unintended harm. Through this meeting, we aim to strengthen collaboration among researchers in midwifery and related healthcare fields. Together, we will work towards a joint publication that maps the roles and responsibilities of midwives across different countries, creating a clear, comparable overview of global midwifery care. This transparency will make it easier to use international research effectively and transfer improvements in care across borders. By using a design-based approach, as you can see over here, we'll develop midwifery journeys that not only support research, but also inspire midwives and other healthcare professionals to make their systems more visible and understandable. So what does this mean in practice? We will create a set of freely accessible templates that anyone can use to map their own system. Imagine if every scientific publication included these templates to show how care is organized. Wouldn't that be powerful? And now, it's my pleasure to hand the stage over to Professor Anke de Jonge, Chair of the Day. Anke is a leading voice in midwifery science and a passionate advocate for evidence-based maternity care worldwide. Anke, the floor is yours.
Good morning, and a very warm welcome to you all. I'm very delighted to present it. What's happening here? Okay. I can wait for it to get on the screen. Thank you. So, I'm very happy to welcome you all here at this working conference. Esther introduced me already. I'm the head of the Department of Midwifery Science, which is located in 2 cities, here in Groningen and in Amsterdam. And I'm delighted to be here. Oh, And a special welcome to all our international guests. Thank you for traveling all this way to talk with us about maternity care systems. It's great. And we also have many people who joined us online, I think about 200. So welcome to you too, although we don't see you. It's always challenging when you sit behind your screen to remain engaged and not keep checking your emails or put up the laundry. So we have tried to build in some things to keep you engaged online as well. So I'm sure it will be exciting enough to distract you from other things. I'm very grateful for Esther and Lisbeth to come up with this topic and let us talk about the differences in maternity care systems. For the reasons Esther already explained, I think it's very important that we look at that. First of all, it's fun to compare things, but also it helps really with the interpretation of research data and helps us that if we want to make changes to maternity care systems, that they're really appropriate. And I'll give you just one example where I really missed this context. And I can give you many, because it's been my desire to know more about systems. Now, I've been around a little while, and in research, I mean, generally too, but also in research. At the beginning of this century, we had reports coming out from Paris showing that the Netherlands had one of the highest perinatal mortality rates in Western Europe. Now, this really shocked us because we thought we were doing quite well up to then. And people who didn't like our system anyway jumped on these figures and said, see, this system is not working. And it was all over the papers that we were doing a disservice to women and our system wasn't safe. And people jumped very easily to conclusions. They did a very simple mathematics. One, okay, we have a unique maternity care system with independent primary care midwives that even do home births, and we have a high perinatal mortality. So 1 and 1 is 2, it must be the system that's unsafe. Now, we did some work on that, already showed that even if you dig a bit deeper into the figures, you get a little bit of a different picture. If you look at perinatal mortality at term, which you should look at if you look at the work of primary care midwives, then you see that the Netherlands is already moving up more to the middle, and even that many countries don't even know their perinatal mortality at term, so you can't even compare. So, and of course, it begs the question, what really are the differences between maternity care systems that could maybe explain these figures? And as we probably see in these 2 days, not everything in the Netherlands is so unique. I think some of the features you see in other systems too, who have maybe better outcomes. So maybe if we jump too quickly to conclusions, we may throw out the baby with the bathwater. So I'm very happy to go into that, but before that let me tell you a little bit about our department. As I said, we are situated in 2 cities, 2 universities, in Groningen and Amsterdam, and we're also linked to the Midwifery Academy in Amsterdam and Groningen. And these are most of the wonderful people who do our research every day, work together on getting more data to support our care. And we have 4 research lines. One is the organization of maternity care, value-based maternal and newborn care, mental health before, during and after pregnancy, and short and long-term effects of interventions during pregnancy and birth. And we have a focus on client participation, women in vulnerable situations, and big data. Now, I was going to show you some examples, but because of time, I'll skip those. And one thing I hope is going to work. I want to show you a trailer of a documentary about the Dutch maternity care system. It's with subtitles in English. If you want to see the full documentary, then approach me. I can put you in touch with the makers, who are Jet Homoed and Anne Oze. And I just thought it would be nice, although it's about Holland, I think you all will recognize the sentiment. And I think it's good because today we're going to talk a lot about figures, about characteristics of systems. And it's good to remind us that behind that are real women and families having babies, and real professionals of flesh and blood who try every day their best to give very good care. Let's see if this works. What do we do now?
I think we have to move forward.
Or this?
Yes. It has to work.
so much home birth, because in America we have less than 1%, so even 10% seems like a lot.
Iedereen beviel gewoon thuis. Nu zeggen ze gewoon morgen.
5 maandjes geleden nu thuis. Ik wilde ook bij de eerste eigenlijk thuis, maar dat ging door complicaties niet goed. Het gaat veel geleidelijker, het is veel knusser en ja, ik voelde me niet bekeken. Ik weet gewoon zeker dat je met rust werd gelaten. En dat vond ik heel erg fijn.
The rest of the world looks at the Netherlands, say, what an amazing country. You have so much home birth, because in America we have less than 1%, so even 10% seems like a lot.
Iedereen beviel gewoon thuis. Nu zeggen ze gewoon in het ziekenhuis. In die 1,5 generatie zijn mensen gewoon aan het veranderen. Het is een grote klus om een kind te baren. Bereidheid om pijn en ongemak en onverwachte dingen te accepteren, die is veranderd.
Maar eigenlijk is de verloskunde het enige wat gezondheidszorg is. Wij zorgen voor gezondheid. De rest is ziekenzorg.
Controle die heb je dus nooit. Wij niet en de banen ook niet.
Het enige zeker is dat het onzeker is.
Ongeacht welk huis of waar ze vandaan komen, iedereen moet hetzelfde meemaken.
Je komt overal, je doet wat nodig is en je laat wat kan. Ik ga niet de strijd aan tegen de tijdsgeest.
Ik wil het anders doen, want ik ben anders.
Ik ben er geen verloskundige geworden voor babytjes.
Ik vind nog steeds de eerste kinderen het leukst, omdat die ouders gewoon nog net zijn.
Zitten ze echt te wachten met hun kindje op hun schoot. Van, hoe je dan naar huis rijdt, dat je denkt, oh wat waanzinnig was dit weer. Wat fantastisch, ik mocht er weer bij zijn.
Nu moeten we weer terug. Kan het ook best wel doen. Hier hebben we iets toe. Oh ja, dat is goed. Anders gaat het zo staan.
Ja?
Don't mind the layout. Just the only thing I still have to say is the practical things. So in the film, I think you see a little bit about the system, but also how systems are changing, changing in time, and maybe that's the same in the countries as well. Okay, just a few practical matters then. As I said, we have a hybrid meeting, so there are people online as well. So to get them engaged, apart from the first presentation, every presentation will start with a question that people online can answer to keep you at it. And also during the presentation you can ask questions in the chat. And we have moderators, wonderful PhD students and postdocs who will moderate those questions and then come and ask some of those after the presentation. Of course you also want to know when the coffee breaks are, very important. We'll have a coffee break around 11, then a lunch break at 12:30 to 1:30. And then in the afternoon around 3 we have a tea break or coffee break, whatever you want to call it. And my ungrateful job is to get us all to stick to time. So I'll try and be strict. What I'll do for every presenter, 5 minutes before time, I'll raise my hand, I'll sit there, so then you know you have 5 minutes to go. So let's please stick to time, because we have a full program, and then everybody can have their share. So, having said that, and maybe you want to change presentation?
Ja, we hebben nog twee vragen voor de audience.
Oh, first, okay. Okay.
disappeared again.
Right.
Yeah.
You want to do it? Maybe because you're doing it.
No, no. Come on.
Okay. I'm completely unprepared for this question, but it's not so difficult. I think if you can go to Mentimeter, then we can all join. And I think online too, probably. Then we can all,
Yes,
yeah,
yes,
it
yes,
can all be
yes.
combined.
Yeah.
So it'll be interesting to see what, from which country you're joining today. I think I can do a blind guess which country most people come from, but let's see if I'm right. There's two colors very similar. Keeps changing colors still.
Online is 20 seconds behind.
Sorry?
Online is 20 seconds behind.
Oh, is that so?
Yes.
Ah, okay. So we have to wait, give them a little bit of time. Okay. I don't know if everybody gets the Mentimeters or so. How long do you want to wait? Or should we just? I don't know. Still people joining. So maybe we should move on because of time. If I don't stick to time, how can I get others?
Het is 24 hoor, dus je hebt nog 6 minuten.
Oh,
6 minutes left.
I can sit here and have a coffee.
So we have 64 from the 270.
Yeah, maybe not everybody
No,
is,
of course.
has worked out how the Mentimeter works. I always struggle to with these things. Shall we leave it at this?
Yes.
So,
You can move
I think
on
my
to the
guess is
second,
right.
second question. If your guess is right,
yes.
it's all about the Netherlands.
But there are also many people from other countries.
Yes.
It's very nice to see.
I was hoping Germany would overtake the Netherlands.
Yeah,
Yeah.
it's just close by.
That's true. That if you're from Germany,
It's closer.
Well, you know that the Netherlands always likes to win from Germany. That's a
I
sensitive
know.
topic. Okay, so shall we move to the next question? Of course, I may need you. Can I just do that?
Yes, you can.
See what happens when I just press a button.
Yeah, you have to wait a little bit. No.
Just thinking about it, or do we have to do something?
This was a new question. We have to stop this.
We've got a question now.
You got a question?
Yeah,
Oh,
it's-
really? It's not showing.
Yeah.
Oh, well, okay. It's
It's already
working.
showing.
Very nice to see you. Okay. Heb je 2 vragen? Ja. Okay. It's just connecting.
Online
We are playing again.
is online wel zichtbaar.
Oh, yeah, okay. So,
Online it's advancing when you push.
Yeah?
Yeah.
okay.
Yeah,
And can you
because
also
the
see the
question is
results?
what's your name and the second question is what's your
Well, we just do it very creatively. If you can tell me the question.
Yeah, and now it's telling you wrong answer and then I give it right.
Same thing, we had stickers.
Wrong answer? Now you know.
Yeah, me neither.
Identity crisis here.
People have problems logging in. You can log in with your private email address on YouTube.
And then you can join the chat.
Right. No idea what this is about, but I'm just passing on the information. If you have a problem getting onto the system, you can join YouTube with your private email address, and then you can also join the chat.
Yes.
Right. Wonderful technology if it works. It's just like during labor, you should never rely on technology. So, let me introduce, with great pleasure, Professor Cornelis Boersma, who is a professor in sustainable health and innovation at the Open University and a health economist at the University and University Medical Center in Groningen. His research focuses on health economic and epidemiological studies, as well as on health policy, system research related to the healthcare promotion and vitality promotion. Cornelis is an independent advisor at Health Ecor, which is a company for sustainable innovation in healthcare, and a health entrepreneur involved in the company's digital health link and sensor health. In everything he does, he wants to contribute to the most optimal, accessible and affordable healthcare for everyone. And it is that ambition to invest in collaboration with private and public parties in sustainable healthcare. So, with great pleasure, I give you the floor.
I don't know, can I walk around or is it, yes, it's, okay. It's visible on the screen. I don't know, I don't trust technology as well. So the introduction already, let's say, probably showcased that I'm not an expert in the field of birth care or neonatal care. I have a pharmacy background and I did research in the field of health economics, epidemiology and health policy. This is actually my conflicts or disclosures. Part of it have already been, let's say, mentioned. And I think what we do a lot from a research, but also, let's say, a policy perspective is really make change in healthcare or in the health environment. And that is what we do in a lot of topics, actually not related to birth care and neonatal care until today. What I was asked to do is give a brief, overarching view on what are we facing in the healthcare field. Probably also what you are facing in the healthcare field in the Netherlands, but also, let's say, Europe, but also outside Europe. I saw Canada somewhere also, let's say, in the pie chart. So what is the healthcare reality? What is the economic reality? Because I'm a health economist. And how can we also, let's say, make change in a way that we provide the receiver with the best possible outcomes in many aspects. So we know, this is a picture from OECD, that we are actually facing, we are faced with a lot of healthcare burden in Europe. We are always talking about the aging of population. So you see the most common diseases from dementia, diabetes, cardiovascular diseases, cancers, but also depression. And with aging of the population, we obviously see that most of these diseases occur in later phases of your life. However, most of these diseases are not actually, let's say, starting to cure here. There is obviously, let's say, something where they, of a time frame before that, where they are developing to a certain extent. So this is the same type of picture, but here it is about disability adjusted life years. They come obviously, let's say, with medical conditions, and here also with age. So you see here immediately the enormous aging effect. However, For example, if you look at, for example, this one, the pink one, psychological disorders, then it already starts, let's say, in early phases of your life. And what we know, for example, from diabetes, that if you have the condition of diabetes, that you are also, let's say, developing other diseases. For example, cardiometabolic diseases like kidney disease, but also, let's say, heart disease. The same is true for psychosocial disorders, because these individuals are at higher risk of developing chronic diseases. So as long as you are able to prevent individuals also in earlier days of their lifespan from developing a certain medical condition, you are also, let's say, able to how do you say, to prevent for escalation to other types of diseases. Very important. So it's not only about the aging of population and lifestyle diseases, it is really about prevention and vitality promotion in order to make this peak in the end as low as possible. And this is an example of how this escalation to more chronic conditions from morbidity to multimorbidity looks like during the lifespan of an individual. Yeah, of course we see in the age group of 0 to 24 less a lower percentage of individuals with more conditions, and that actually increases with your age. Good news is, in many countries, that we become all elder, so the life expectancy increases. But, and most of the people ask actually, what is this drop? That was actually the COVID pandemic situation. But we are increasing, we see increasing life expectancies. This is a Dutch picture, but higher life expectancy doesn't necessarily come with healthy life years. So here you see different conditions from cancer to, for example, diabetes. Here we see a loss in healthy life years through disease, and here a loss in years through mortality. And what we see is that in essence we do, this is actually blue is 2015, pink is 2040, we gain life years, but we also gain more morbidity. So we actually have more life years with more morbidity. Important here is that there are, I think, I don't know whether that's the next picture, but you can look into this and make, for example, a difference between people on gender, but also, let's say, looking at this picture on economic status and things like that, then you will see the same kind of patterns, but that the differences will become bigger. So it is very important also, let's say, to really understand the heterogeneity behind these pictures. Another phenomenon is that we see in many countries that the percentage of individuals working in the health sector or healthcare sector and the social care sector is increasing. So in many systems and economies we need to do more with less people, but for healthcare we need more people. We don't have these people in order to deliver the care we want. So you can see this in an OECD picture. The white dots is actually what it was a couple of years ago, and it increases actually in many parts of, in this case, Europe. So what is then the economic reality? In many systems we are spending more and more, and this is in purchasing parity numbers. We spend an awful lot on healthcare. The Netherlands, for example, is in the higher end together with Germany and Austria. And it is also, let's say, the case that these expenditures are actually increasing. It is, however, dependent on how you're also, let's say, looking at healthcare budgets. So in the Netherlands, for example, we try to reduce the growth in healthcare costs, and if you look then, for example, look at these figures here, it is 1.3, 1.0% growth. But if you look at, let's say, the absolute amounts, it's really substantial money. And that is also what the outlooks show, that if you look from, for example, 2030 to 2080, then we are more than doubling actually the healthcare expenditures. So in English there is the saying, you can't iterate on a burning platform. I think many healthcare systems are a burning platform where we try to iterate on. We're not really, let's say, transforming the system to make it, let's say, sustainable for the future, but we are actually keep looking at it as a budget cost where we need to make certain choices in which are not necessarily in the benefit of the future of generations to come. Many words to say that we really need to change something, to my opinion. This is a picture for the Netherlands, and what you see is that this is the blue box is actually what healthcare expenditures were in 2015, and the yellow or orange, the yellow-orange color is actually part of the demographical developments, aging of population, and the orange part is actually other types of developments, and you can think about the implementation of innovation, but also, let's say, inefficiencies in the system. So, the benefits. This is a picture also from OECD where you see actually the annual growth rates of different types of care. Or healthcare budgets. I couldn't find a picture with, let's say, costs for neonatal care and birth care. But what you see is that the dark blue box is actually the period growth 2015-2019, the light blue 2019 to 2022. And you see here there are some, let's say, growth. Inpatient care, outpatient care reduces, and you see prevention that it really, let's say, increases. However, if you look at prevention, and prevention is, to my opinion, also, let's say, following the comments I made in that disability adjusted life year graph, very important in order to move the needle in a different direction. But if you look at, let's say, this growth, if you put that in perspective, from 4.2 in this period to 23.6% in the period 2019 until 2022, if the budget is very low, then, let's say, the percentage growth is also, let's say, contributing in not such a substantial way to, let's say, the expenditures we do in the prevention area. So, for example, 4.3%, let's assume that the rest is then roughly 95%. If that grows with roughly 3 or 4%, is much more than, for example, the 4.3% on a very low budget for prevention. Another phenomenon we saw is the COVID part. Still not an enormous increase, but pre-COVID prevention was in European countries around 3%. 2020, 2021, it increased a little bit until 2021, 5.5%, and now it is actually decreasing again. And that's also what we see in the Netherlands, for example, in the previous a government, they actually cut out a lot of budget which was actually meant to be spent for prevention. And then I'm not talking about vaccination, because many countries we spend roughly around 0.5% on vaccination, which is also in your area very important, I think, to a certain extent to protect a mother and child, but that reduces as well. This is a picture I already explained. This is about the differences in healthcare consumption between in gender and age, but I think you can make many other figures where you try to understand how, for example, individuals with certain characteristics consume healthcare. And one of the, I think, important criteria, or how do you say that, one of the important topics here is also, let's say, income rate. Social economic status. So the demand for healthcare increases, aging effects, lifestyle effects, and increasing care supply, innovations. The supply of healthcare in many systems comes under pressure. There is a substantial increase in healthcare expenditures. We need to here and there our systems cut down budgets on certain elements. We have a shortage of healthcare professionals, and this is already a problem. But if we are actually in a situation where there is no economic growth, this becomes a bigger issue. So it is important to look how we can invest in better quality and durable, affordable care. Try to see if we can, let's say, invest in efficiency where possible. And see how we can also broaden the scope, because what I think is that we consider healthcare as a good where we need to pay for, whereas I think it is something where you need to invest in order to also, let's say, generate broader health, but also, let's say, societal and economic benefits. Because how the healthier we are, the better we can contribute also, let's say, to society and economies. So, so this is already what I said, trend of growing healthcare costs is unsustainable, affordability of healthcare remains an issue, and what we all want, we can agree upon that, is that we want qualitative good, accessible and affordable healthcare. So the question is, how are we going to create that, access for all, affordability, and reward also, let's say, for innovative solutions or other ways of delivering healthcare, which is most of the time challenging. I most of the time use this concept, this is the quintuple aim concept, not because I like concepts and to talk about it, but I think it is quite interesting to see how you can implement this. Because this really starts with the patient first. In many, we are talking a lot about the patient or the individual, and patient first. But how are we really going to make that patient or individual experience better in order to serve for a situation that population health increases, which, and that has been researched a lot, has the potential to reduce cost or deliver more care per euro or dollar invested, and which is also, let's say, much more interesting and nice to do from a healthcare professional perspective, and also, let's say, consider health equity in this. Because if you satisfy a patient with less means here, you have more room to also, let's say, spend time on the individuals who need more time. In the Netherlands, we have in GP, at the GP level, in the waiting room, now and then such a leaflet, 10 minutes for one complaint. That is exactly not this. So we need to turn it around. And I put some midwives here as well now, and pregnancy and neonatal care. But you can actually leverage this for many, how do you say that, diseases, populations. But what we most of the time do is that we actually pay for operations or things we do. So we have most of the time vertical annual agreements on reducing healthcare production with budgeting operations. It's more, let's say, compensation for volume. Not everywhere, but most of the time it's the case. If you spend an hour, you're being paid for an hour. Or if you have a certain activity, you have a tariff for that. And then you get what you have, what you currently have. If you turn it around and you put actually, let's say, the outcomes, the health outcomes, the cost outcomes, the efficiency outcomes, and maybe even the environmental outcomes first, and you have a certain objective there, then you are going to think about what do we need to do in treatment, early identification or diagnosis, prevention, how do we keep people as vital as possible in order to make this value chain as optimal as possible. And then you need to think about other types of organization, you need to think about other types of contracts you close with payers, you need to think about other ways of, let's say, generating data and actually use that also, let's say, and the aftercare to optimize your value chain. And you're not going to look at innovations, for example, treatments, as something you need to use, but something you need to consider or you consider in order to reach your goal. So this is an example. I dove a little bit, let's say, in this topic in the Netherlands. The Dutch colleagues are more familiar with this than I am. But this is actually how we actually the RIVM. I think it was the RIVM. This publication for the RIVM thought about or actually promoted the fact that you really need to create a solid start for newborns, and that starts already before children are born, and really approaches in an integrated way. And then you are actually also including, for example, elements like poverty and things like that, like I explained. But you also need to look in line with, that is actually where I did some research on, you need to look at ways in order to identify certain medical conditions in an early way, for example through newborn screening, but really approach it from the whole value chain. Yeah, there's another element. I already said something about outcomes, economic outcomes, so health outcomes, economic outcomes, but the environmental outcomes also, let's say, become more and more important because it is not only a threat for the health situation of individuals, but healthcare is also, and these are actually all kinds of examples. So you have, for example, 800,000 excess deaths in Europe due to air pollution, so that's quite substantial. But healthcare is also, let's say, contributing to this footprint, the emission footprint. In the Netherlands, this has been estimated at roughly 8% of the total emission. So that is substantial. And I think it is more and more important, we are always in the Netherlands in fan of certain lists, and most of the time we are very proud if we are in the top of the list, but here we are not so proud being at the top of the list because it means, let's say, from a health footprint perspective, we are not doing so good here in the Netherlands. And then I found this picture that, for example, that air pollution, or this is actually particular materials or fijnstoffen in Dutch, that is also, let's say, causing premature deaths in many countries. So the environmental situation is also very important from a health perspective. So, as a health economist, we are most of the time looking at, for example, a change in the organization. Is this a cost-effective change? So, what are the costs? What is the budget impact of that? And then you are actually, let's say, calculating the so-called willingness to pay. So, if that results in better outcomes of, for example, pregnant women, are we then willing to pay additional money for that? But you can obviously imagine that this is not always, so if the outcome here is positive, considering certain, let's say, how do you say that, thresholds, and you say, okay, this is cost effective, so we should be implementing it. It can come with additional cost, and we have an affordability problem because we don't have the money. So I think it is very important to really make the change that we are also, let's say, broadening the scope and see how we can make change by investing now and also, let's say, look at the benefits later on. Most of these evaluations, you want to see immediate cost savings. But if you are going to change also in your field or area things in the benefit of the individual and also, let's say, the healthcare professionals involved, then it most of the time takes time. So I think that we need to move more from a budgeting approach to an investment approach. Invest in change, otherwise it's not going to happen. And in that line of thinking, you also need to consider different elements. I think equity is very important because populations are heterogeneous. So you need to include it. Value of hope is very important. This is, for example, a value if patients are diagnosed with cancer. Hope is very important in order to have a higher quality of life. But you can't obviously, let's say, put a number behind it. So these are all, let's say, elements to take into account. That is actually a health economist who have actually written a paper about this to also identify these other elements. And also productivity. So if you are able to avoid certain healthcare outcomes, you have also the possibility to, for example, keep contributing to the economy because you are able to work. Labor productivity. Another thing, because most of the elements which I actually mentioned, for example, also for innovations of organizational innovation, is that we look at technical considerations. So, what does this mean? Is it still effective enough? Are the outcomes okay for the individual? Is it cost effective? Can we implement it? That's not, so if everything here is green and okay, doesn't necessarily mean that we easily implement it. If you have, for example, with your peer colleagues a discussion about it and there is not, how do you say that, they are not in favor of it, so there is some rejection on it, it's not going to happen, and then you will keep discussing things. So it is very important to capture this part and have all kinds of green checks there, but it is also, that's very important to get the support here, and make it possible to implement it. Very briefly, I think I also said something about resilience. I think we are now actually, in terms of we need to do more with less, or we have the need of more, let's say, individuals working in healthcare, and the demand is actually, let's say, increasing, the ask is increasing. So it is really important to see what the impact of not being resilient is on societies. And I think this is for change, is the new economic governance framework of the European Committee quite interesting to see how we can make it possible to actually invest in the resilience agenda and get really the community engagement in making the change along all these different parts of the circle. And I think to make really change, we need to, I already said something about payment models. We really should look at different ways of making the change possible. That's not going to happen with fee-for-service models. So really look at different models. I skipped that in one of the previous slides, but in one of the pre-conversations I had with you, I explained it, or I illustrated this based on a hospital in Spain, in the Valencia region, which actually came in private hands because the region had some financial problems, and they are actually, let's say, compensated based on a tariff or a budget per individual in that region. And the hospital has now, let's say, an incentive to keep the patients or the individuals out of the hospital rather than being compensated for the fact that an individual is admitted to the hospital. So, I think my last 30 seconds. I think it is very important to move from the current silos in many systems to ecosystem collaboration. And ecosystem collaboration and integrated care doesn't mean that everybody needs to do something, but that you make the decisions about who is going to take the lead, who's not so at this stage not involved, who will be later involved, and things like that. I think we should more look at outcome-driven care rather than, let's say, volume-driven care, more from a budgeting to investment, because if we invest in health and healthcare, it also generates broader societal and economic benefits, what is actually the next bullet, and I think sustainability can be an interesting driver for change, because, for example, movements from healthcare facilities and things like that, digital solutions, are already, let's say, contributing to that. So I think it is important to also, let's say, use it as such. That was it.
Fantastic, thank you. That's very interesting and dead on time. If we all do that today, then that's fine. So, oh yes, the moderators are coming. So, I'm curious to hear what questions came out of the audience. Maybe you just want to ask a question.
Come from?
Yes.
I think you need to stand here maybe for the...
We did have some problems with the chat, so we hope we find the people the way to ask the questions. But we had one question from Nora Vallejo. I don't know if I'm pronouncing it right.
Perfect. She's
yeah.
Irish.
She is stating that the evidence is accumulating, highlighting the benefits of midwifery care. However, low-tech approach to care is constantly competing with the belief the more tech the care, the better it is. How to challenge this?
No, I think that is what I said based on the value chain. I think we are most of the time looking at technologies as something we need to implement. But if you turn it around and you put actually, let's say, the objectives first, then it's a mean to, how do you say, make sure that you are actually reaching that outcome. And then it's not, let's say, about high tech, it is also, let's say, about low tech, you know. I think it is very important that we are not pushing innovations. I'm really against pushing innovations, because I think, for in particular technological innovations, I think we really should look at other ways of, let's say, achieving these outcomes. But on the other hand, you also need technological innovations.
Yeah. So keep the goal in mind.
Yeah, yeah. So it shouldn't be an objective to implement technologies.
Yeah.
It is an objective to generate outcomes, making use of technologies.
Yeah.
Low tech, and if needed, high tech.
Yeah. Okay, thank you. I hope this is an answer to Nora's question.
We will go look back if there are another questions, more questions, but otherwise you can...
No more questions from you?
No, from the chief.
Oh, right,
from
okay.
so
Well then,
presentation, I think.
up to the floor here. Just a few minutes. Quite a few minutes actually.
Maybe here, yeah.
Any questions that came up here? Yolanda?
Yeah, so I wonder, as you say, we should go from a siloed healthcare system to more ecosystem. How do you go about the interest there are in the field of keeping it this way or wanting to produce more?
Yeah. No, that is very important because that is actually taking us away from, let's say, these collaborations. And these interests are all over the place. And I think that's also my experience. If you put all stakeholders in one and the same room and actually put the quadruple aim or the quintuple aim element in front of them, they all agree upon, let's say, we should do things differently. Mm-hmm. And if you are able to end in that, or actually achieve that situation, that's already the first major step. Because most of the time, if you are actually entering a room where you're going to discuss change, whatever it is, then people are actually sitting there with their interest. And that is actually hiding them away to make the change. If you are, let's say, in a situation that you can say, okay, we are all committing to that objective and we agree upon that, and then you have a discussion what that specifically means for your specific position and things like that. It's still not easy, but it's at least, let's say, more easy. But I think interest, if that is position, financial, that is really a big problem. Those innovative contracts help, but also with that, if you have, for example, healthcare or payers who say, okay, we are going to do something in terms of volume reduction in hospital, and they make an agreement, then it can be the case that the payer is actually sitting on the back of the hospital to say, okay, but you should reach 20%. And I think it's stupid, because if you leave it to, let's say, the parties themselves, you can probably reach 25% volume reduction. I'm just making the numbers up, but you know, it is really, don't say that you are changing things and already, let's say, with agreeing upfront on what that needs to be.
But how do you feel? How can you influence policy this way? Like in the Netherlands, we have the integrated care agreement, which now is in the news. Like the progress is very slow because of interest and because of so how do you get to that common goal, the shared goal?
The interesting thing is that you need to, let's say. So I think the integrated it's not a success yet, but it's a first step. And I think we are not doing the things we need to do under that umbrella. But again, it's the first step. I think that as long as you're doing things, let's say, really from a system approach, it's not going to happen. And I think you need to be bold and entrepreneurial, not, let's say, in terms of, let's say, setting up a company or whatsoever, but just, let's say, in the way that you are really going to do it, and create a kind of, let's say, situation where you show that you can do it differently, and then hopefully the oil sport or the other, that they see that you do it in another way and in a good way. But, you know, that's not always easy, that's very difficult.
Thank you. I think there's another question from the chat. After all.
But I'm really thinking about this. I think you need to use the system, but do it without the system.
Nice quote. How do you do that?
We received another online question about your slide about the footprint.
Oh yeah.
The question states, why is the number in the Netherlands so high and what parameters are used?
There is a report on that. The number, I think in other countries it's also high, but in the Netherlands it's relatively high. There are many parameters in it. It is actually, let's say, what healthcare actually produces in terms of CO2. That can be buildings, that can be traffic, it can be medicines, it can be waste. It's very, very broad. But it is, for example, also, let's say, the travels patients make to the different healthcare facilities. Yeah. And in that sense, it's quite strange because in many other countries, they're not so condensed and well populated or populated as the Netherlands. We have a lot of traffic movements in the healthcare field.
So what do you think is then particular for the Netherlands? That it comes up so high?
I do not necessarily. I think in particular, let's say the travels is very high, but also the buildings.
But not the density. Like we have a high population density.
Yeah.
A lot of people in small areas. That's not the main problem.
No, not necessarily. That would be actually one of the things that you could say. Okay, then we should not have so much movements from one to the other facility. So, for example, I need to look at the details. But what you, for example, see with the fee-for-service model in the Netherlands, if you have a back pain problem, you visit the neurologist, you go home, you get, let's say, a new appointment, you go back, and it's really, let's say, it's not a one-stop shop.
Yeah.
And you know, after COVID, we have not really, and I think that's in many countries the case, not really embraced the whole digital solution area. We are actually back to normal and even worse.
Even worse?
Yeah, in certain areas we are even worse because also there the compensation model is not necessarily helping. So in many countries, if you do something in pilot setting, it is not actually, let's say, phasing out what we did. It comes on top of what we do.
Yeah. And maybe other countries do better in that because if you have long distances,
then it's easier.
You're forced to.
Yeah.
Okay, we still have time for one or two questions, I think. Unless everything is so clear. Yeah, maybe following on from the question from Yolanda, what we are always struggling with, and we did a whole invitation on that, is what you see in healthcare, what you showed a little bit, is always the push towards acute care. So that's why you show the prevention, percentage-wise it increased, but in absolute expenditure it's very small. But that's because if you, in one system, have to put the acute care and prevention and supportive care, you invariably see in all countries that the acute care always wins beyond the point of optimality. What do you do about that?
No, I you want solutions? It is interesting because it is today in the media, but framed a little bit differently. Let's say, it is a topic about, let's say, obesitas. We wait until it is obesitas, but you can do exactly the same for dentists. You wait until something is wrong and then you are going to repair. So we as health economists, we wrote a nice manifesto about that, and this was picked up by one of the Sembla in the Netherlands media broadcasts. And they framed this completely different. So what we did there is actually to really make the case that we need to invest in prevention. That's much more value. So we made actually the analogy with a sink with all kinds of patients in it who have obesitas. You can do whatever you want, but you need to do something with interventions and things like that. Make sure that you put the tap, close the tap. And then it is really, in this case, we also did, let's say, an economic analysis for one of the drugs, but then it is really framed as, you are looking for medicalization, but that shouldn't be the case, you know. We need to make sure that we allocate more money for prevention and vitality promotion in order to make sure that you need to treat less or you need to spend more time and money in acute care. But that paradigm shift, you know, there are so many interests, political because they don't have the money, media, payers because they don't see it as their task, and you know, that is really difficult. But I think there you really need to stand together and to make clear that you make that change. You know, in the dentist field is exactly the same. You know, there you have actually, but it's the same also. Let's say with the pharmacists. You have actually healthcare providers who really want to invest more in lifestyle promotion and to get patients from diabetic medication. So that are really the preventive pharmacists. And you have the ones who are just, let's say, throwing the boxes to the patients. I think really the latter part, we need to make that part as small as possible, if you ask me.
But that's a real challenge because it's much more profitable to earn money from Ozempic than to do anything about prevention.
Yeah, that's also, let's say, now the frame in the media that we did such an analysis. But that is one of the interventions: high tech, low tech. No, you need to invest, let's say, in prevention because then you don't need these products, or you need them less.
So somehow we have to make prevention more sexy, but how?
But that is really the investment thing I mentioned. You really need to make sure, and also, let's say, we have in Central Planbureau, I don't know, but they are also, let's say, quite, although those institutes are also, let's say, quite fake about, let's say, the value of prevention. Mm-hmm. And that is because there is a delay in doing something now and pay for it, and let's say the benefits later. And I think I have some ideas about that. We also, let's say, created some models to make that change happen. And what I meant also, let's say, based on your question, you need to do it with the system, but not make use of the system, but not in the system. If you can make it possible to change something and you come to the conclusion that you have actually transformed the system, then you did the right thing. If you are starting up actually a kind of system discussion, you are here, you will sit here, also you will sit doing that in the next coming 10 to 20 years and nothing changes.
Thank you. Well, that's a great sentence to close with.
I think you really need to make the change yourself, and what I said based on that question, if you are agreeing on, let's say, what you want to achieve, make sure that you achieve it.
Mm-hmm. Well, that's a task for us all. Thank you. Thank you very much. So, Lisbeth, are you going to change the presentation?
Yes, of course.
For our next speakers, we are going overseas to Ireland. And we are very delighted to have two speakers from Ireland, one online, physically here. So welcome Nora Falleggio. You've just asked a question as well. I don't know where you are, but welcome. I can start talking already. Oh, your hand from there. Nora Falleggio is an advanced midwife practitioner at the Coombe Hospital in Dublin. Her primary clinical focus is the supported care pathway, which is a pathway dedicated to women considered to be of normal risk in pregnancy. And her clinical interests include women's experience of maternity care, models of continuity, and a personalized approach to care. And she has recently collaborated on guideline development and is currently seconded to the National Women and Infants Health Program, focusing on standards for the supported care pathway and continuity midwifery services. She will speak together with Professor Deirdre Daly, who is a professor in midwifery at Trinity College in Dublin, and she's the principal investigator in the maternal health and maternal morbidity in Ireland, MUMMI study, many of you may know, which is a longitudinal study exploring the health of first-time mothers. And she's also the director of the Trinity College Trinity Center for Maternity Care Research, and is a member of the National Severe Maternal Morbidity and Maternal Health in Ireland groups, very long words. And she was on the National Women and Infants Health Program's academic partner on the evaluation of pilot of postnatal hubs offering extended postpartum care. Wonderful you are here, and please tell us all about Ireland.
Huge thank you, and it's great to see you again. And a huge thank to Elizabeth and Esther for the kind invitation. May I lift this?
You can.
Yeah, just.
You want to lift it?
Up, yes. Take me away, please. It's okay. We go back. That's perfect.
Yeah,
perfect.
Perfect.
Perfect. Gahanwak Garamaka. That means really good, thanks a million. And before I start, I want to say, Tabrona and Nachwil Nora and Shah. I'm really sorry that Nora isn't here. That's the Irish for that. And to Nora, hello, I hope everything is well at home, and I'm thinking about you and I missed you. And I'm doing the whole presentation on behalf of something to make sure everything runs smoothly. We were given a task. We were asked to describe midwifery in our countries in 20 minutes with specific questions. So you are a hard taskmaster.
Yes, we were.
What? But thank you, because it means we're going to have fairly comparable information. I'm going to present in about 18 minutes, so most of my slides are pictures, very little text. Some have a lot of text, but there's keywords highlighted in blue, and there's one slide at the end that's just for information only that will generate discussion tomorrow. So, before I start, a question for the audience.
We skipped that question because it's too hard to.
Okay.
It interfered too much for this presentation.
Oh, okay.
So sorry.
Oh, no, that's all right. I'll repeat it if that's all right. The question was, the Irish for midwife is Cnáth Seachas, which means midwife now. But the old Irish word was an bhean glúna. Now, for those of you who like charades, that translates from Irish, from 3 words in Irish into 4 words in English. An bhean, woman, glúna, knee, the woman of the knee. So there was a woman of the knee giving birth and a woman of the knee supporting her. It also means in Irish, o glúna, go glúna, from generation to generation. That's lovely. Yeah. Anyway, here we are. We are an island off Europe, and we're a beautiful green country, about 500 kilometres long from our length, and 270 across. But we still take a long time to get around it. Our population is on the increase, and we're at about 500,000 at the moment. That's up from about, or 5.5 million at the moment. That's nearly doubled since the 1980s. Last year there was 54,000 births in the Republic of Ireland. That figure, you need to look at it in context. So look at what was happening 50 years ago. 74,000 births. 20 years ago, 76,000. So this is what the births look like in Ireland over the years. And I'd say most countries there are similar dips, maybe not to the same extent, but we're increasing and decreasing. And a lot of that is linked with environment, society, social issues, etc. Fertility rate is 1.5, so we're declining. The age of first-time mothers is increasing. It's increased by about 2 years or 3 years in the last 20 years. Now, this is where terminology means everything and understanding it. So I've said that there are 19 maternity hospitals in Ireland, but if I understood Academic Medical Centre correctly, I might have put the 19 there. 4 of these hospitals are tertiary centres, and there are 3 in Dublin and 1 in Cork. So they are really high-tech, high-level intensive care. 19 maternity hospitals, number of birth ranges from just under 1,000 to over 7,000, and that's in one of them about 8,000, 9,000. But there might be 10,000 women attending that hospital with gynecology issues, etc. 3 of those hospitals would be, 3 to 4 of them would be really women's hospitals as opposed to just maternity, so they've all care. They cater for 99.5% of all births in Ireland, because only about 0.5% of our births are at home. That has increased since COVID, even though numbers are small. We have a very different system in that midwives have major collaborations both in the community and hospital. If you look community, most are with general practitioner, who's our primary care doctor, but those women's health physiotherapists, this is changing. Public health nurses, years ago they were nurses who had completed the midwifery education, now they don't need it, but they're the ones who will see. Their role is really child health surveillance, but they look after woman and baby, and they're obliged to visit within 72 hours of birth. The hospital system is changing because teams and specialist teams and advanced care teams have developed over the years. So midwives in hospitals will work with all sorts, obstetricians, lactation consultants, perinatal mental health personnel, psychiatrists, paediatricians, women's health physiotherapists, etc., etc. Pay is really straightforward because most midwives in Ireland are, particularly those in the hospital, are all employed by their hospital. So they're paid directly. That pay comes from our government tax, general taxation to the government, to the Department of Health, to the hospitals. And they're even sitting within regions now, so funding comes down like that. And then midwives are salaried. And their salary depends on their role, and that role depends on the grade, managerial responsibilities and years of service. So there's considerable difference between all of these. If you're in the community and you're self-employed, this is key, and giving care and offering women care for home birth, then you will have, if you're working within the home birth scheme with the health service in Ireland, then you have to have a memorandum of understanding, a contract with the provider. And they will, there's a system within that agreement to manage pay. So in that sense, we've described it as direct. There's some indirect private pay that can come from a woman's private insurance, but that's less, and that happens less frequently. There's 4,500 midwives registered in Ireland, just over it. That's registrations, that's counting bodies, it's not counting whole-time equivalent. And there's about 22 self-employed community midwives. Hospital-based midwives work across what we're now beginning to call integrated care, you mentioned it earlier, across hospital and community. So most of the hospitals I'm talking about here have a lot of community-based services. So 4,600 midwives, just over 4,000 of those are offering direct woman care. We have 37 practitioners who are registered to advanced level, like my colleague Nora. And we have 105 midwives who are registered midwife prescribers, and these are all prescribing as a registrable qualification. These are the numbers we have of registrations in Ireland, number of midwives. And what I want you to look at are the two at the bottom. You will see that it's changing. We are recruiting, because of the shortage of midwives, we are recruiting more midwives from within the EU and outside the EU. In 2020 was the last time we actually published the report on the count, but there are over, at that stage, 5 years ago, and it's probably double by now, there were 60 community midwife-led care clinics in Ireland. That's aligned with these hospitals. In 2025, we just finished, this is 2025. In 2022, Ireland started listening to the research and what women were saying about postpartum care and implemented extended postpartum care in 5 pilot sites. I had the pleasure of leading that evaluation in 24-25, and what women said was phenomenal about the care they received. Every word was exactly what a woman wanted. Women described it as pivotal, saving them, all of this really powerful language. So those clinics are now extended out to another 4 sites this year and a total of 13 sites by the end of 2026. Now I have them here as big blobs there. It's not a site, it's clinics dotted all over the place, close to women's homes. Law and regulation. So our registration, our registering body is the Irish Nurses and Midwives Organisation, and it's founded upon the Irish Nurses, or the Nurses and Midwives Act of 2011. They have a role to protect the public. This was a time where midwifery, the term midwife in Ireland, was subsumed into nursing for years, but they recognise it now as a completely separate profession. They were responsible for registration, regulation, control, and the standards of education and training. There is one prohibition in that, in the Act it says no one can attend, for reward, attend a woman in childbirth unless they're a student, midwifery student or medical student, or qualified, of course. Our healthcare service has different values in different places. This is the general healthcare service, has a mixture of private and public healthcare, but we're committed to, all parties in the political parties in Ireland are committed to universal healthcare. So healthcare free at the point of service for everybody. Within the maternity care services, every woman who is ordinarily resident in Ireland is entitled to free maternity care, and that's maternity care throughout pregnancy and birth up to 6 weeks postpartum, and now with the extended postpartum care that's gone beyond 6 weeks postpartum. Our maternity care strategy, Creating a Better Future, it's been revised at the moment and is due up next year, has 4 strategic priorities based on health, well-being, mothers and families that are supported, empowered, woman-centred maternity care, and care that's delivered in partnership with the women. So those are the underlying priorities. Within the care, maternity care context, those priorities are delivered over 3 care pathways. Supported, assisted, specialist. Supported care, the healthy, well woman who has no obstetric or medical risk. Midwife-led, midwife-delivered. Assisted care, midwife and obstetric working together, but midwife-delivered. Specialist care, obstetric-led, so for the woman who has underlying medical complications. Our national standards for safe care also has themes of safety and quality focused around the woman and the baby at the very centre of it. And it lists all of those dimensions. Our Nursing and Midwifery Board of Ireland, our midwifery standards, also have values. And this year they've introduced a new one of leadership. But their respect, accountability, competence, trust, working together, collaboration, and now leadership. And they're the exact same ones that run through the philosophy and our code of ethics and practice. And the philosophy says that we will, again, deliver care in partnership with women. The woman is the primary decision maker. Childbirth is normally and usually a physiological event. And we value the empowerment of midwives. Those are the key terms that tells you what we're supposed to be achieving. We believe, and this is what it tells us, that care is holistic, grounded in understanding of the social, the emotional, the cultural, spiritual, psychological and physical experience of each individual woman, the uniqueness of woman. And again, our code of ethics and conduct is underpinned by and based on these core principles again, same core principles. So you have the same words and language and terms emerging throughout all of the documents. They also have set up a standard that the Nursing and Midwifery Board are responsible for handling complaints about us and complaint about the practice. There's different levels, so there's a preliminary meeting first of all, and then there's a fitness to practice. But they all manage that because their primary role is protection of the public. Now, here's another history lesson. This is midwifery in Ireland over time. Before, here on the very left, is before we joined the EEC as it was then. And this is where we are now. So we've come a long way from a one-year programme in midwifery now on to a 4-year BSc, Bachelor, Direct Entry Bachelor in Midwifery programme. It's been running for the last 20 years nearly. And we also have alongside that an 18-month higher diploma in midwifery for those who are nurses and are becoming midwives. Both programmes are delivered by the universities in partnership with the health service provider. The career structure that I mentioned, advanced and specialist, emerged around about 2000, shortly after we had a 9-day strike in 1999. There's a midwife strike in 1999, and that was one of the structures to emerge from it. In the 4-year programme, self-funded, both programmes meet the EU directive. Students on the first one, we take in about, it's a 48-month programme at the moment, 45 from 2027. Higher diploma in midwifery programme in students. These students are already registered general nurses who are now have become employees of maternity hospital and are funded indirectly via the health service to undertake the programme. So they're funded at their full salary level. There's a lot to do for them. There are some other mandatory educations within the hospitals, mainly emergencies, neonatal resuscitation, emergency skills. I've only mentioned some of them there. Most midwives would undertake those at least every 2 years. And there's a mixture of funding for those, employer self-funded with or without time, depending on the continuous professional development one. Midwives can also undertake an MSc in midwifery and practice leadership, which we offer in Trinity, or other MScs. And that can be self-funded again or employer-funded, either in part or full, offering part-time time back or all time back. And PhD is a requirement, an essential requirement for a university lecturer post. And for PhDs, there are some scholarships available. They're highly competitive. There's some full-time scholars generally have a stipend, but it's a full-time course until it takes about 6 years if you're doing it yourself. Our government has this vision that care is going to be from the model from graduate to advanced through those graduate BSc, specialist, advanced practice. I'm not focusing on this, but they're there for people's information, and that differentiates what an AMP does, an advanced midwife practitioner, clinical midwife specialist, from the graduate. These are example areas that they work in, and these are the type of medical and obstetric risks. So, alongside all of them, so clinical midwife specialist, fetal assessment, diabetes, cardiovascular, women with various types of medical or obstetric risk. Examples of advanced midwifery practice, these are very different throughout, and there's a range of low to no medical or obstetric risk factors to high risk factors. And these are the areas that those advanced practitioners are currently working in Ireland. This is 79 of them, and this is fresh off our lead midwife's desk in 2 weeks ago. So they're working all over the place, some in women with cardiology, some in urogynecology, sexual assault, ambulatory gynecology, very different. Thank you.
Thank you, and that's very well in time. So maybe our moderators can come and see if there are any questions on the chat. In the meantime, are there any questions here? Please. Maybe say your name as well.
I'm Alison Cummins.
Hi.
From Australia.
Well, hello, you're very welcome.
You mentioned that postnatal care was beyond 6 weeks now. Could you explain that and how that happened?
Oh, I would love to. So, you know, well, okay, you do know because I know I read all the research, same as Hank. Every publication you read that has something to do with postnatal care, with exceptions here and there, talks about it being Cinderella of services. And as someone said to me years ago, well, even Cinderella got to go to the ball. Postnatal care doesn't get anything. And it's neglected. And out of research in Ireland, the MAMI study set up in 2011-12. And I suppose publications started to emerge 2015, 16, 17, and the ones on postnatal care were saying the same thing again and again and again and again and again. And I think that there's a couple of things that are important here. Women were describing postnatal care as being all about the baby. They described themselves as invisible in the midst of a very service that was supposed to be centred on them. The MAMI study is also, you talked about public participation in your research. The MAMI study is all about co-design, co-participating with women. So most times, if I'm standing on a podium talking about the MAMI study outcomes, there'll be a woman standing with me, probably introducing me and talking first, or maybe I won't be talking at all. And certainly on all our TV and radio interviews, it's always the women who talk. So that's been going on persistently since 2015, 16, 17, 18, saying the same thing. Then our National Women and Infants Health Programme themselves did a survey in 2020, and guess what they found about postnatal care? The exact same issues, that it was just screaming out as a neglected area. And our then Minister of Health there was other issues. There was other issues, I mean, I cannot take this out of a wider context in Ireland in terms of, we had issues about women's health, cervical screening, miscarriage, things not going, I'll just say things not going according to plan or well, but there was other issues. And there was also other issues within the maternity care services in different places dotted throughout. So the government set up what they called a Women's Health Task Force. All the documents are online, they're beautiful. And what they called underpinning that was a radical listening project. Listening to women and what women wanted. And they invited us all in, and we all, professionals and everybody, and we went in. And that was 18, 19, 20, 21, 22. By 2022, funding had been secured for extended postnatal care in 5 pilot sites in Ireland. New sites, new services, led by midwives, with women's health physiotherapists in them as well. So it is a wonderful example of a government turning, now I'm saying turning it around and working, but when the decision was made to do it, it was done, set up and evaluated within 3 years.
And it also shows how you have to be persistent. You know, it doesn't come overnight. No?
Yeah, I can't recall who said it to me, but if you look at policy to implementation in practice, well, in Ireland, that doesn't happen overnight. It takes about a decade.
I don't think it happens anywhere overnight. That's the lesson, isn't it?
And if you look at, if you think it takes a decade, then you think of, and I'm thinking in the timeline of the MAMI study, 2012 to 2022, it only took me a decade. Well, it didn't take me, it only took the women, because it's their voices.
Yeah.
That's what did it, their voices.
And when do they get discharged? And when does it end?
Extended to how long?
It depends.
Depends.
So we have the evaluation is not available publicly yet, but I hope it will be soon. Some women talked about needing to notice there. Some women said it was just enough, they had enough. Some women described the ideal time to end it as being that 5 to 8 week period. Other women, remember, who get into it and use it, may very well want to or need to continue to use the service of the women's health physiotherapist, which will continue. So, and the 5 sites and their satellite clinics operate differently across the country. Even though we're a small country, quite diverse, some of those sites are rural. Some of them will be. So the new sites are going to be based in Dublin. They're going to be very different. One of the other sites was in Cork, which is very different from 4 of them. So they're all slightly different in how they function and interact. And that's deliberate because it's the director of midwifery in those sites that knows their population and catchment area.
Yes, thank you. I think some questions from the chat.
Oh,
we're doing fine for time. We still have 10 minutes.
I have to go home now.
You have to go home. You're not going anywhere.
The first question was from Pien Offerhuis, and she states that Ireland has 3 levels of care, and she asks who decides on the level of care a woman needs.
Okay, so these are the 3 levels. So this is supported, assisted, specialist. And who decides? Well, the woman herself should know what level she is, but when she comes for her very first visit with the midwife, that's when that health assessment, and I'm going to introduce the word risk assessment, will take place. But if you're coming in and you're a healthy, well woman with no medical, no obstetric risk factors, you're low risk, no risk, you should be on the supported care pathway. If you have a risk factor, so it might be diabetes, so you're now not that low, no risk, you move up into the assisted care pathway. Then the specialist. So this is consultant-led and midwife and consultant delivered. So this is the woman with your cardiac disease, your renal transplantation. So there's ones within. Those will be the key issues. And you start on one and you can move up. Or equally, you can be on one and have a referral and move back down if something resolves. That's the way it should work.
But it sounds like the midwife decides when a woman should go one level higher. Or if she does the supportive care.
Yes, yeah. That's
She
ideal.
decides.
That doesn't always happen because within the system, midwives, women, a woman may choose. We don't have any private maternity hospitals in Ireland, but a woman may choose to attend a consultant obstetrician privately. Now, she may be very well, healthy, no low obstetric risk, but she's buying something that she can't or believes she can't get elsewhere. Continuity of care.
No, thank you. Do you have more questions?
I'm definitely going home now.
Yes.
Make it work.
One question is, are any midwives working independently from hospitals?
Those 22, what I called self-employed community midwives, are independent, self-employed practitioners. We did have another group of Ireland, and they have a contract, they have a memorandum of understanding with the health service, because that memorandum is quite strict in terms of the criteria, but it enables them to have health insurance.
And also gives them access to hospital if they need to come in with a lady.
That works differently in some places, yeah. If the woman transfers in, the care will transfer in, and the care will transfer to the hospital. But that can work differently depending on the local relations.
And with
So
differently, do you mean sometimes the midwife will continue looking after her?
No, I mean technically then the responsibility of care comes to the hospital.
Right.
Yeah.
Same like here. Yeah.
Now, whether the self-employed community midwife stays to support the woman or not, I would say varies considerably.
Okay. Mm-hmm.
Thank you. Then another question. Is there a special training program for midwives to become an A&P?
Yes. But it's not a special training program. It's beautiful. It's really gorgeous. Nora will tell you all about it. You have to be educated to master's level.
Okay.
It was initially offered as, so it came out as this structure we have now emerged after our strike. And it was devised and it was divisive. It was devised after there was no proper career structure for midwives within the system we had. And you can see it's the same all over the world. You became a midwife, you became a manager, that's it. And if you wanted anything else, you left and went into education someplace else. So this became specialist. It was also, and advanced, it was also linked with educational attainment, increased responsibility and accountability, and increased pay. So there was a remuneration with it as well. For the masters, it's a master's in midwifery, or for the advanced midwife practitioners, master's in midwifery. But the post, initially when it was set up, the health service had to decide, I need this post. So it was a service identified gap that they gave it. So Nora's an advanced practitioner in supported care pathway, and she set up new services and leads them completely.
So it looks like these advanced midwife practitioners all work in hospital, not in the community. Is that right?
But a lot of Nora's clinics are out in the community completely.
Mm.
Even though she's based in and paid for by a hospital.
Say that again?
Even though she's technically employed with the hospital, a lot of her care is
in the community.
Based in the community.
Okay.
Yeah. The vision for integrated care.
Mm-hmm. Those were the
Those
questions
were
from
questions.
online.
Thank you
Very
very
good.
much.
You're well. Get through all of them. Any more questions here? We still have a few minutes.
Yeah, David, my name is Nicola Bauer from Germany. David, thank you for your very big presentation. I was kind of very happy to get so many information. You were talking about midwife prescribers. Is that also on the master's level, or?
Yeah, it is. It's different. There's a midwife prescribers course that's delivered both within a master's program
okay.
and it's also registerable with
Okay.
our board.
And what are those midwife prescribers allowed to prescribe?
It depends. What I might do is, there's a list actually, and again, Nora's a prescriber, so I will let her talk more about that because you have to prescribe within your scope of practice.
Okay. So you have a list and you know what can I do?
Within your scope of, yeah.
Okay. Thank you.
Are the advanced practice
You want to say your name? Also,
sorry,
or maybe,
I'm Katrien Beekman from Belgium. We are also investing in advanced roles in Belgium, but we are still in the beginning. So I wondered, is the government paying those salaries? Do they have another check, or is it the hospital itself that decides that they will invest in it? Because I saw you have 79 in the whole country. Is there a quotum, or is it just if a hospital wants to invest, it is an investment, or does the government say each hospital must have 3 advanced roles, for example?
No, the government doesn't dictate, but if you, a couple of slides before that, one of the slides I had was on model to advanced practice. That's the government's policy.
Okay, so they are behind the idea, but the hospitals have to invest themselves.
The hospital invests, but remember the hospital is getting the funding from the government too.
Okay,
You know.
so that's similar.
And initially the posts have to be service identified.
Yes.
So you can't decide, I'm going to have an advanced midwife practitioner in, you know,
Yeah, okay.
anything. It has to be there. And 79 now. The government had initially says, the government's vision is that 3% of the nursing and midwifery population would be educated to advanced practice level.
Okay, so that's...
So if you take 3%, that would leave you with 120 advanced midwife practitioners in Ireland. That's going to change because of what they're doing. And I wouldn't be one bit surprised if that goes up to 5% and more. There's a lot, you know, and it's as previous speaker was saying, I mean, we're really short of healthcare professionals, including doctors. And it's not that these are not many doctors, these are advanced practitioners.
Thank you very much. I think we have to leave it at that. Okay, so it's coffee time now. Yeah. You're dying for some caffeine or tea, whatever. So let's be back here sharp, 11:10. We can stick to the program. So far we've been great for time. And I'll see you back then. Enjoy your break. Oh, 10:13.
For the group.
Oh, of course. I've got lovely chocolates here. That's alive, to make you jealous. I don't know, it must be Irish chocolates, or maybe Belgian chocolates from Ireland, I don't know. But, Irish.
Ja, maar ik
wel elkaar ook zien.
Ja, ik ben hier ook nog even.
Ja.
Let's continue. I know there's a lot to discuss, but we have lots of time today. Let's try to stick to time a little bit. So I want to continue. As you notice, I've started wearing my glasses. You saw me struggling a little bit when I was reading. I'm still in the phase where I'm trying to deny that I need it. But I think it's time to surrender. So, the other thing we didn't mention, Lisbeth pointed out, you see our brilliant photographer, don't even know your name. Julian is taking wonderful pictures that we may need use for, I don't know, social media probably and all other things. What we haven't asked your permission is if there's anybody objecting to it, let us know. And somebody also suggested maybe it would be nice for those of you who are here that we take a picture all together. And maybe we do that at the beginning of the lunch. Because at the end of the day, you never know what's going to happen. Where they are. So we all collect where we had a coffee and then take a picture and then go for lunch. Yes? Right. Now we move even further overseas. We go all the way to Canada. And we'll listen to Megan Furnival and Beth Murray. Megan Furnival is head of midwifery at London Health Science Centre in Ontario, Canada. She's a registered midwife, clinician, researcher, and adjunct professor. As a founder and CEO of Empower L, she designs innovations for maternity care. Her work advances women's health, leadership, and dignity in childbirth. Megan is dedicated to improving outcomes for women, newborns, and families. She will give the presentation together with Beth Murray Davis, who is a Canadian midwife, educator, and researcher, serving as an associate professor at McMaster University and is the scientific director of the McMaster Midwifery Research Center. She teaches students in the undergraduate and graduate programs, focusing on clinical skills development and research methods. And her research explores experiences through the voices of service users with a focus on person-centered and equity-oriented models of care. And we look forward to hearing from you.
Thank you. I am also in the glasses denial phase, so I may be taking them on and off and doing all sorts of random things. Thank you very much for having us. We're really excited to be here to talk about midwifery in Canada, and hopefully we can start to draw some good comparisons with the Ireland presentation. I think where we landed with the trivia and questions is the Mentimeter is up for the online people, but you can't see it. So my question, I will just read it out loud, is when do you think midwifery in Canada was first regulated, 1994 or 1964? So people with the Mentimeter can go ahead and answer that. Maybe a show of hands, who thinks it's 1964? Who thinks it's 1994? Oh, you guys are good. Okay, that is the correct answer. Okay, let me see if we can advance our slides. So we're going to talk about midwifery in Canada. And what I thought we would do first is go through some of those template slides that we were given, and then we're going to dive a bit more deeply into some of the themes. So Canada is the second largest country in the world by total area after Russia, so we have a lot of land. The province where Megan and I live is Ontario, so we have over 1 million square kilometers in our province alone, which is pretty staggering. It takes several days to drive out of Ontario. There are just over 2,000 midwives across the whole country. And we really only have two categories of midwives. We have registered midwives and then we have Indigenous midwives. And it's a huge priority in Canada to have midwifery and to be really responsive to cultural safety and to encourage the growth of Indigenous midwifery. So if you're interested in learning more about Indigenous midwifery in Canada and the work that they're doing, you can scan the QR code. But Indigenous midwives are working a lot on the issue of bringing birth back into Indigenous communities. They have had a long-standing policy of evacuation for birth, so that's really a harmful practice to most communities. Let's see, what else can I tell you on this slide? As you probably know, we have a very small population in respect to our landmass, so our population density is quite low, our average birth numbers are there, and the average number of children per person is listed there too. I should just also mention on this slide. So we have really most midwives in Canada work in the course of care model or caseload midwifery. And most of the midwives in the country are considered independent contractors or self-employed midwives. In some provinces, you can see them listed, they might work in a salary model, but they still all do that caseload model of practice. So, moving on to hospitals, I think most of you are probably aware that Canada has publicly funded healthcare, and it is administered at a provincial level. So provinces and territories, their government really oversees all the funding and administration of healthcare in that region. So from here on, we're probably going to focus a bit more on Ontario, just because that's where we live and work. But it's also the province that has the longest standing history of midwifery in the country and the largest number of midwives. So this is a big, actually it's already zoomed in, so we may have lost this is Ontario, the big landmass. Hospitals are in blue with the little bag, and then midwifery practices are the red dots. As you can see, most of the population in Ontario is really clustered in this southern region, so we'll zoom in a little bit there so you can see what that looks like. So we have in total in Ontario 140 hospitals. They are all publicly funded. We don't have any private hospitals. And most of them are divided through our 3 levels of hospitals. So level 1 hospitals are for low-risk births. They might care for newborns greater than 36 weeks, and the care providers might be up to 30 minutes away at any given time, so they're not on site. We have level 2 hospitals, which are for moderate risk, so newborns could be 34 weeks and up. They do offer 24/7 care and have to be able to mount a cesarean section in 30 minutes. And then we have high-risk centers or tertiary centers where they can provide full high-risk care to pregnant people and newborns. They'll have an adult ICU and a newborn ICU. Those are often also our academic teaching centers, not all of them are, so you'll see only 6 of them are academic teaching centers. And then midwifery is really scattered around those communities. So midwifery clinics are the red dots, and it's available in 250 communities across the province. And out of the 140 hospitals, only about 96 of them offer birth care, and midwives are at 90 of those 96 hospitals. So in terms of collaboration, one of the first things, and we'll get into this a little bit more, we're going to talk more about collaboration and how we work, but midwives work in midwifery practice groups in the community setting. And so those practice groups could range from 2 midwives to up to over 20 midwives in a practice group. So that's really the group of people that midwives interact with most regularly. Within those especially big practice groups, you might see that people are grouped into teams or pods. And so the people in your team or your pod are the ones who you're going to work with most regularly. We also have a requirement that there's always 2 midwives present at a birth. So again, you're working most collaboratively with those people that you're sharing call and care with all the time. But then beyond that, if you're in a big practice group, you're also going to collaborate with your other midwifery colleagues. And then the people we consult with most regularly following that would be obstetricians, general practitioners, pediatricians, and then more broadly into the community, we might refer to lactation consultants or physiotherapists. The funding piece is, again, fairly interesting, again, thinking of what it looked like in Ireland. I've only done the funding in community-based midwifery because we don't have hospital-based midwifery. So this is our community model. Again, it's publicly funded, so clients don't pay anything out of pocket to receive care from a midwife. And it comes from a separate branch in the Ministry of Health that has the entire overview of the midwifery program. And how it works is the government, so obviously citizens pay taxes, that goes into the government to pay for healthcare, and then to administer midwifery, the money flows through a transfer payment agency. And so the way that it works is the transfer payment agency actually approves the number of care, like courses of care that a midwifery practice in a region will be able to offer each year. And the way that the billing cycle works is an individual midwife needs to complete a full course of care. So that has to include the pregnancy, the birth, and the postpartum up to 6 weeks to be able to bill for that client. So the minimum is 12 weeks of the person being in care and a midwife-attended birth. And once those criteria have been met and the 6 weeks postpartum has occurred, that midwife will individually bill the transfer payment agency, who then flows the money to the midwifery practice group, who then flows the money to the midwife as an independent contractor. The government does attach some fees to, or some money to the amount that goes to the practice. So when the money flows from the transfer payment agency to the midwifery practice group, there's a portion that's retained for overhead and equipment and things like that. This is very different. We're the only healthcare provider in the province that works in this model. Everything else is fee for service. So physicians will bill for time and visits and procedures and things like that. So, going a bit more deeply into some of the themes that we were asked to talk about, I thought this was not one of the original themes, but we really can't talk about Canada without thinking about geography and the history of midwifery. It was first regulated, as you correctly identified, in 1993, and slowly all the other provinces and territories have really followed suit from there. But the last province in the country just regulated midwifery in 2021. So it is very new there. And so that experience of a short history and small numbers really influences how we work and the issues that we're facing. So I'm going to zoom through some pictures of the country. This data is from 2023. You can see kind of the look across the country, and I'll go through different provinces more quickly. You'll just see total number of midwives and the percentage of births that we do. So that's British Columbia, Alberta, Saskatchewan, Manitoba, Ontario and Quebec are in the middle of the country and have some bigger numbers. And the numbers just got released for 2024, and in Ontario we are doing 20% of the births now, which is nice to see. Eastern provinces, so New Brunswick, British, I can't talk today, PEI, which is Prince Edward Island, Nova Scotia, and Newfoundland and Labrador have very small numbers of midwives and a small percentage of the births. And then when you look at the northern areas of the country, so the Yukon, Northwest Territories, and Nunavut, again, very small numbers. So as you can imagine, in many parts of the country, it's actually very lonely to be a midwife. To go into a bit more detail about the finances, so midwifery is publicly funded in all the provinces and territories, as I said, except for Newfoundland and Labrador. They're always just a little bit different, and they have a different fee-for-service kind of approach. So, as I mentioned, the key thing about the finances for us is that it is this bundle of services. It is course of care based, and that means that there's some kind of pros and cons associated with that. Our typical caseload for a full-time midwife is 40 clients or courses of care that they're going to be billing for per year. As I mentioned, there is an amount of overhead that comes to the practice to fund the business of midwifery, equipment, and the government has also committed to funding the same number of graduates per year and jobs. So when people graduate as a qualified midwife, they are guaranteed to have employment. We can't guarantee where it is, but there will be funding for each of those positions. We do have an experience-based increased scale, so there are 6 levels that people move through with different experience, and their salary will go up at each of those levels. To give you a sense of the salary, so for a starting midwife with their base caseload amount, and then if you add in what we call the second midwife or backup fee, so remembering that there's always 2 midwives at the birth, when you go as the second midwife, you get $250 for that one birth. So if you put that all together, the starting salary is around 102,000 Canadian per year. And my colleague Liz Darling's done a lot of research on, again, the kind of pros and cons of this model and the way that we're funded and the impact that it has on our profession. And it's certainly been seen as a really big success in terms of incentivizing autonomy and incentivizing woman-centered care, but it really also has been seen in the sustainability work that we've been trying to address in the province it's a really significant barrier. So because we can only be paid as that kind of course of care, we can't bill for components of care. We end up double billing the healthcare system if there's consultations or transfers of care. And then also it means that a midwife really only can do that whole course of care, and if for physical reasons or other reasons they don't want to do all those parts of it, they end up leaving the profession, and so attrition and burnout are significant issues. The other thing is, of course, midwives have lots of skills that they could bring to the wider healthcare system, maybe providing postpartum care to physician patients or contraception planning and things like that, but we aren't able to do those specialized services. It has to all be contained in that full package of the childbearing cycle. In terms of regulation, we are regulated under the Midwifery Act and the Regulated Health Professions Act, and we are established as an autonomous healthcare provider that can do independent care, primary care throughout that sexual and reproductive health cycle, so encompassing and focusing really on that prenatal, intrapartum, and postpartum care for low-risk pregnancies. We have a College of Midwives that regulates our profession and manages things like registration and discipline and things like that, and they protect the public. So our scope of practice is similar to the international model of a midwife, that really we should be able to do all low-risk things throughout that childbearing cycle, so conducting normal vaginal deliveries and providing care to newborns. We also order laboratory tests and can perform ultrasounds for point-of-care scans. We arrange for consultation and transfer of care. We do prescribe and administer a fairly decent list of drugs, which is helpful. We do suturing. We've had some things added to our scope, like ultrasound, as I mentioned, or first assist at cesarean section. And we also just recently had more contraceptive care added to our scope of practice, so the counseling related to that, and then insertion of IUDs and other options. Each province has their own regulatory body. So as I mentioned, we have a College of Midwives in Ontario. Then there's also a national regulatory council that brings together all of those regulating bodies. And they oversee the national registration exam, and that exam allows graduates from any province to have reciprocity and work in whatever location they want. So they might be educated in Ontario, pass that national exam, and they could work in British Columbia. And they have laid out the competencies of a midwife, and they're the 7 characteristics in the pink box, which kind of mirror a lot of the ones that were in Deirdre's presentation as well. So core values of midwifery in Canada, it's focused on respect and autonomy and equity. We have what we think are our core 3 pillars of practice, or our philosophy of care, and that's continuity, informed choice, and choice of birthplace. So continuity is, I think you're all familiar with it, the idea that you have a small team of midwives who follow you throughout your entire childbearing cycle and are present ideally at the time that you give birth. And we try to model that continuity of carer and continuity of care itself. And Megan and I have been doing some research on continuity, and we know that about 93% of people actually have a known midwife present at their birth. So we're doing pretty well at it, which is nice. And we believe that that continuity really strengthens the client-centered approach that we think is so foundational to midwifery. And so the way that we operationalize that is that a midwife has their caseload of clients, and they are on call 24 hours a day, 7 days a week. And are then available to go when their client pages them. They will work in those small call teams, and Megan will talk a little bit more about that. We also operate under informed choice, so lots of language that's really similar to what Deirdre mentioned, that we see the client as the primary decision maker, and that our role is to support their choices, to provide information and evidence-based practice so they can make decisions that are the ones that align with their values and wishes. One of the choices and options that we discuss with everybody is choice of birthplace. So we can attend clients in home or hospital, and in some communities there are birth centers, and midwives have to maintain their competency and skill to be able to go through all of those settings. Midwives do have full hospital credentials to admit and discharge and provide care when people are in hospital. So we see that you can follow the client in terms of that transfer from home to hospital. Nothing changes in who your healthcare provider is. And you may have seen the numbers, I think, or Megan will go into it, but we have a fairly decent home birth rate, which we're pretty proud of. In terms of education, so talking about the different pathways, midwifery is a direct entry program in Ontario. It's a 4-year university program. Across the country, there are 6 universities that offer the training. In Ontario, we have 2 of them. And so you don't require nursing qualifications, although if someone was a nurse previously and they want to become a midwife, there is an 18-month shortened program where they can go through in an accelerated pathway. And there is a bridging program for people who've trained internationally and who move to Canada and want to work as a midwife. The undergraduate program is very much focused on clinical experience and that balance between academic coursework and lots of hands-on practice. So 6 out of their 9 semesters or terms are in clinical placement. So they usually graduate having attended over 100 births. So lots of hands-on stuff. We do have a graduate program that we just launched at McMaster. It's the first in the country. We have had 4 intakes. And it's really building that career pathway, although it's not formalized in the way that Ireland was highlighting that advanced practice, but it's giving them the foundational skills for that. So a lot of it is advanced clinical practice and then leadership development skills as well. Midwives are required to maintain qualifications every year in emergency skills, neonatal resuscitation, and CPR or life-saving skills. And then lots of midwives take other additional continuing education as well, so things related to contraception or medication abortion, again, surgical assist and ultrasound, as I mentioned before, perinatal mental health courses, and things like that. And I'll hand to you.
All right, Becca's done such a good job of getting all of that in way faster than I thought she was going to, so this is good. So what I'm going to do is probably skip over some of these things and talk more about some of the statistics and some of our outcomes. So let me just find the right spot here. Care, scope, risk, moving down. Okay, yeah, so Beth, as she talked about, we predominantly focus on low risk, and so it's been really helpful to hear your situation, because we are finding that our scope is expanding. So in the last 10 years, the government has been very happy, the college has been very happy to expand the scope, but without actually any compensation adjustments. And then what we're finding, because I work at a department that's, I believe, the biggest in the country, so I get to hear about the direct impacts of that scope expansion on sustainability, and so it's a real problem. So it's nice to hear that other countries have come up with different ways to kind of niche out some of those skill sets so that we can compensate appropriately, address the healthcare broader needs, but then also maybe not burn out all of the midwives as well. So Beth's done a really good job of outlining kind of that traditional low risk approach in caseload midwifery. But we are seeing, which I'm going to show you, some of the variations that we've come up with to be able to meet the needs of complex care, of the patients who have complex care as well. So if we look at how we structure everything, we have predominantly caseload midwifery, as Beth had said. So most midwives work in the community. We are starting to see a little bit more at the hospital level. And so you've got your caseload midwives, and then you've got your hospital integrated models. So in order to get a hospital integrated model, you need to actually apply for funding from the government, and then it's a very large pool of applicants, and then they're selective about what you want to build. So it's very much up to the midwives in their communities to decide what are the needs of the community, to create the grants, to make sure that we've mapped it out, and then to pitch that to the government, and then the government decides who gets the money and what we get to build. So hospital integrated midwifery, as Beth said, we don't have a lot of that yet. There's a huge demand for it. Midwives are asking for that as an option. A lot to do with sustainability as well. But we do have in a few centers models that are very much collaborative with obstetricians as well. We also do home birth, as many of you are aware, and we do have some birth center. We don't have many birth centers, but we do have that as an option in some very sort of specific cities. And then as well, when we're looking at Canada, there are some more collaborative teams in rural areas. So we have communities that are very remote. So that's where you would see midwives working more within health teams, looking at collaborating across different providers to meet those broader needs. And as Beth said, Ontario has the largest, sort of most established midwifery system. And we conduct about 20%, but unfortunately, there's still about a 40% of applicants for midwives don't get midwives. So I think on our wait list last year, in our practice alone, we had 1,000 applicants on the wait list we were not able to accommodate. And we are seeing midwives starting to reduce their caseload numbers just to be able to sustain being in the job, because the volume is just too big as the scope expands. So it's becoming more tricky for them. So when you look at some of the statistics, we attended, so these are 2024 numbers, we attended in Ontario about, as Beth said, 20%, 19 to 20%. 86% of those births were in the hospital, 11% were at home, and then 2% were in the birth centers. When you look at the type of birth, last year's numbers, 72% of births were vaginal births. We had about a 22% C-section rate and a 5 to 6% assisted vaginal delivery rate. Our center has implemented other structures, so we've been able to actually reduce our transfer of care rates and increase our vaginal birth rates through some of the interventions that we've created, some of the training opportunities we've done, which has been really helpful. And then from a pain relief perspective, you're looking at about 39% epidural rate, 15% with nitrous oxide. Breastfeeding rates, 71% of people are exclusively breastfeeding at 6 weeks. And as I said, 6% of home births are first-time birth people who are having their first babies. And then again, the demand is still very high, so it's quite sad that we can't meet the needs. So over the last 2 decades, just really quickly, midwifery in Canada has transformed. We've got a new model at our centre that I'll chat briefly about. It's called it's a very long name. It's called the Interprofessional Midwifery and Maternal Fetal Medicine Expanded Program. So we call it the TIME program. So what we did was we built a program where midwives could work in high-risk obstetrics cases, because these women would traditionally not apply to be eligible for midwifery care. They really need the obstetrical intrapartum care. So we created a model where these complex cases would have access to midwives to be able to do prenatal and postpartum care, but also meet those needs, a lot of addictions, a lot of mental health. And so what we're seeing is that those patients would traditionally be stuck in the hospital under observation. They would have the same sort of model of care with obstetrics, but now they're able to go home earlier, they're able to get more one-on-one time with midwives, and so we are in the process of finalizing that evaluation, and so far it's been quite promising. So we're really excited about that as well. And then again, sustainability is really why I do the work that I do, because it breaks my heart when midwives leave the profession, especially they love the work. It's just the intrapartum care can be really tricky. So a lot of our work is really focused on building other mechanisms for midwives to stay in the job, which is what I love so much about Ireland's postpartum concentration, because it's such a need. And then I'm just trying to think, Beth, what else I can talk about that you haven't already covered. I would say the transfer of care rate is helpful to know. It's about 36.5% to obstetrics, but 18% of that is labor. So we have done a good job in our center of keeping track of the data. So we're able to measure year after year anything that we've done and how we've been able to affect the transfer of care rate. For us, it's helpful because the government that's their argument in many cases, is we're not going to make more midwives because you're not that cost effective because you're transferring care so much. So being able to track that transfer of care rate has been very helpful. And it's been one of the mechanisms by which we've been able to get the hospital on board with other types of models and programs. And then you'll see lots of other programs cropping up, and I would say there's not a systematic approach to that, unlike Ireland, unfortunately. So you've got midwives that are starting postpartum clinics, or you've got family newborn clinics, and you've got Billy clinics, so bilirubin testing for newborns to get them to go home sooner postpartum so they can come back and have some of that repeat follow-up testing done. There's a lot of emergency room diversion programs popping up where we're trying to get women and babies out of emerge, because unfortunately that's a dumping ground for many of the women's health issues that we're seeing. It's really unfortunate. So we're also very keen in helping midwifery integrate into the broader healthcare system to meet the needs that we know are historically not a priority. And this is just a quick summary table that obviously just highlights midwifery in a snapshot in Canada and what we do. So
I was inspired by Esther and Lisbeth, because you put this in one of your publications, so that we can all speak the same language and have that summary of what care looks like in your countries.
Yes,
that's everything.
And we would welcome any questions.
Thank you. It's very interesting, and I think Canada was a country that looked at the Netherlands for when you change the system, but you've moved on a lot more than we did. Maybe look at you again. So that's very interesting, and I think there are questions.
Yeah, we have a few questions from the online audience. Astrid School asks, in Canada, midwifery salaries are increased with experience. How does this progression work? Is it based on years of experience, or does it additional education also plays a role? And how does this influence more experienced midwives to keep working?
So it is essentially experience-based. Once I think it's 30 births and then another 30 births, it's kind of the more you've attended in your career, the more you move up on that pay scale. And I would say most people feel like it's probably not enough to incentivize them to keep working. When you've been in the career for over 20 years, you've already been at the maximum the pay scale for a long time. So the career incentives, or how we keep people growing in the profession, is an issue. As I mentioned, we have that master's program where we're building leadership and we're building advanced clinical practice skills. People right now take that master's degree because they're interested or they're passionate, but it doesn't lead to anything for them. They don't get to do more in their job. They don't get to, offer anything further. So we have to really look at, for the people who've been practicing a while, how do we keep them in the profession and how do we keep them progressing in their interest and skill set?
Very interesting.
Yeah.
I have a question from Pien, and she asks, how are data on pregnancies and births which are attended by midwives registered, for instance, for monitoring and research?
So in Ontario, we have a provincial data set where every single birth gets entered into that, and we've been able as midwives, we actually have to complete that data to get paid, which is really interesting. It's good and bad. As you can imagine, we hate entering all that data, but it means we've been able to actually tailor some of the questions that are in the provincial data set to meet the needs of our research questions and interests. So we do have a question, for example, about did the birth occur in water? On the provincial big data set. So yeah, it's been helpful to have that and to have some input into it. So yeah, we can use all of that for research purposes.
Okay. Teresa Lam, she asks, if a client lives in an area with a small number of midwives, who will provide care if the number is too low?
If the number of midwives is too low? It doesn't really happen because midwives just never go off call. They just do what they have to do, I think, how midwives work. But Megan mentioned it, that especially in other parts of the country, we have seen more collaborative models. So British Columbia, for example, particularly in their rural and remote locations, they have ways that they've had midwives work with GPs to stay on call and provide those services. In Ontario, I think it's just at the midwife's expense, basically, to never go off call.
And it can be really challenging because their catchment areas are massive.
Yeah.
So sometimes they're 3 a.m. driving 3 hours to someone's birth because the size of the geography is so big. So it's a very large point of contention around sustainability, unfortunately.
Yeah, it's a very common reality, even in Ontario, that lots of people have a catchment area of 2 hours from one side to the other. Yeah.
I have one final question. From Tara van Haren, she asks, is nitrous oxide used at home?
Yes, it can be used at home. So midwifery practices, if they would like to offer that service, need to obtain the equipment and be, maintaining the equipment and ensuring that they're following all the safe policies, but they will often bring nitrous to home.
Okay, thank you. Questions?
Thank you. Maybe there's 1 or 2 questions here as well. Maybe you want to mention a name?
Yes, I'm Natasha from the Netherlands. I was wondering what the motive is behind the second midwife at the birth, and I was also wondering if the sustainability of midwives has something to do with the second midwife being there, or is it because of because you want to make it safer?
Yeah, it's a good question. So the role of the second midwife is to come close to the time of the birth, and their responsibility is to be there for the newborn. So sort of the primary midwife has been there throughout the duration of the labor, does the catch and the repair, and it tends to the mother essentially, and then the second midwife attends to the baby, and then supports the primary midwife with whatever else is needed. So that's how we organize it. And even when you have a hospital birth, we call in a second midwife to do that role. In British Columbia, midwives don't attend as a second. They use the nurses in the hospital, which they argue actually has been very helpful in terms of integrating them and being more collaborative. For us, it means that there's 2 midwives and we just go into a birth room in a hospital and do our thing, and the rest of the labor and delivery unit may never know what we're up to. So it can be isolated in that way, and they don't see our good work all the time. They're not involved in it. Is it related to the sustainability issues? Potentially. So there's more births that you're going to. So for example, as a full-time midwife, if you go to 40 primary clients, you're also going to 40 backup births. So you go to 80 births a year. So that volume is a thing, and that's 80 nights where you're probably up and you've lost sleep and all of those things. So I think it's a piece of the picture. I don't think it's the leading cause of our sustainability issues, but yeah, it's a factor. Thanks.
Last question probably? Oh no, I think 1 or 2 questions we start time from.
I am Brenda from Belgium. I have a question also in the topic of the sustainability. Do you have any data or insights about sick leave among midwives?
Oh yeah, we do. I don't know it off the top of my head, but We do have the provision for like benefits and leaves of absence through our professional organization, but because midwives are self-employed contractors, sometimes taking a medical leave and things like that is more challenging. They might not have appropriate funding for that. I do think we've had a high rate of people leaving the profession for health-related concerns, as I mentioned, because you have to provide that full course of care service. Like I worked with someone who was my preceptor when I was a student who just had physical issues that meant births were almost impossible, right? 24 hours at a labor, standing all the time, but there was no way for her to just do clinic, right? She couldn't just be an antenatal midwife or just be a postpartum clinic-based midwife. And so when health issues arise, it does mean that then we've lost a whole midwife. We haven't been able to capitalize on their skill set and what they could bring to the profession. So I think it's a piece of our sustainability issue. For sure.
And I would say that the Association of Ontario Midwives captures the amount of midwives on stress leave. And I believe the last time I looked at this, it was almost 30%. Wow. It was a massive number, and so many that our health insurers keeps changing because they're like, you're too expensive, right? And so I think it speaks to what he had mentioned this morning around the health economics and looking at the workforce and expecting a group of predominantly women who are taking care of their families to try to burden these gaps in health services that women need in the broader healthcare system. So it's like visible everywhere within our profession. You can see the burden, and it's really hard because midwives want to work. They really love the work, so it's very depressing when they have to take a leave and they don't want to do it, and usually they wait too long. And then practices don't have the structure and the capacity to be innovative in the models within their own teams. So we talk about this all the time about our department has 4 practices. How do we cross-pollinate our resources, expand them, whether it's for teaching or whether it's for, for births? It doesn't really make a lot of sense the way that we have it, but it really is left up to us to create that, and that's the harder part, right? The disruption.
There's that trickle down or domino effect of someone taking a leave because their whole caseload now has to be reassigned to other midwives, and then that burns them out, and then it just keeps going.
Yes.
We have a lot of Very interesting. So now we move a little bit closer to home, our neighboring country, Germany. And you're going to change the presentation. Why I introduce Nicola Bauer and Anna Brodersen. I'll wait till you finish, otherwise it's sort of behind you. So, Anna Brodersen studied midwifery at Fulda University of Applied Sciences, and since 2018 she's been working as a self-employed midwife, providing antenatal and postpartum care, lactation counseling, and occasionally attending home births. She also gives lectures for students on ultrasound for midwives, one of the newer disciplines in Germany for midwifery. She will talk to us together with Nicola Bauer, who is a certified midwife since 1988 and has worked in hospitals and a freestanding birth center. And she worked as a research assistant in Osnabrück, did her PhD on models of midwife-led care, and she's now a professor of midwifery at the Hochschule für Gesundheit in Bochum. Excuse my German. Currently, she's professor of midwifery at the medical faculty of the University of Cologne and head of the Institute of Midwifery Science. She leads the bachelor study program Applied Midwifery Science and the master program Advanced Midwifery Practice. So please.
Yes, thank you for the introduction and thank you for the invitation. We have to apologize in the beginning because our slides aren't so fancy. And secondly, we are not native speakers, so we will talk more slowly because Ireland and Canada were very fast, but I believe you will understand us. So you see our map here, and on the left side you see the Cathedral of Cologne, that's where I'm from, and down there you see Bavaria, and that's where Anna is from. And you could say, why? How could you connect over this country? We are both in the German Society of Midwifery Science, and I'm the president, and Anna is working in social media for our society. So that's why we are standing here together. Our question is perhaps a little bit difficult to answer, and perhaps we have to talk tomorrow about it, but I was very fascinated about Ireland and also Canada and the regulations. We don't have this kind of regulations in Germany. So our question is, how can we generate valid figures on midwifery care, because we don't really know how many midwives work in which parts in Germany, in order to ensure the best possible care during the reproductive phase of women, their children and families. And you know, I believe it's also that's our topic, that's our goal. We want the best possible or the optimal care for women and their babies. I believe I will go on and not wait for an answer.
I maybe one or two answers in this area.
So it's a big question.
Any ideas?
If you have the answer, it would solve many problems.
Just one for today.
First, do you have to register when you enter the profession?
No, you don't.
Start?
No.
That's a good solution. Yeah.
You have to make sure that you have an insurance in case something happens, and you have learned your profession, but that's all.
But then you know the number who has an insurance, and how do you get paid as midwife?
That's only
about the finance we will talk.
We will talk about
because then you have a registry somewhere.
Yeah, but only for the independent midwives and not for the hospital midwives. But we will show you in a minute.
Well, if you don't know, if you don't have a register, how can you, not you, how can Germany ensure that its citizens have freedom of movement of a regulated profession within the context of the EU directives?
Yeah, that's difficult, because that's one of our big topics. And
because you don't, if you can't show registration in the Netherlands or in Ireland.
Yeah, we will show you on the next slide. Okay. But that's a really big topic, and I believe we will talk tomorrow about it. And it's we are talking about this. You said I'm a midwife since 37 years. Since I was in midwifery school, the vocational training, that was a topic. How do we get the correct numbers of midwives, and who are they caring for? Okay. And perhaps the audience online will have some answers for us later on. So Germany is one of the most populated states in Europe. We have over 83 million inhabitants and 236 people per square kilometers. Our birth has declined, the birth rate, but last year there were 677,100 babies born, and our average number of children is 1.35. And you see the number. We have 28,000 midwives. We believe to have 28,000 midwives, roundabout. And we have a different system. So you can choose to be an independent midwife. So we have approximately 18,000 or nearly 19,000 midwives working on community-based home birth in the homes of women or in birth centers. But we don't know what they are doing, because they could only provide antenatal care or only postnatal care. We know the numbers of midwives who attend home birth or work in a birth center. And we have hospital birth midwives. They're around 12,000 midwives. But these midwives are also allowed to work as a freelance midwife. So they have mixtures. We have 3 different groups of midwives. So you see already our obstacles encountered midwives in Germany. The hospitals, your questions were sometimes very challenging. So Anna and I, we were researching. So we believe we have 1,600 general hospitals and 600 teaching hospitals. That means medical students and also midwifery students are working in their practical phase in the hospitals. We have 612 labor and delivery units, and this declined. 1990 there were nearly doubled, 1,200 units, nowadays 612. There are always more units closing because they are rather small. We have units with about 600 births per year, and the biggest unit is in Frankfurt. It's 4,500 births per year. And we have 117 freestanding birth centers all over Germany. Should I do this or you? Yeah, this. Okay, we have to just talk when we change. So you see, we have 98% of the women give birth in the hospital and about 2% out of hospital. In some bigger cities like Berlin, it's 4%, but all over it's 2%. And last year, there were 15,486 births in a birth center or a home birth. You see about 7,000 home births and 8,500 birth centers. And you can see we have 16 federal states that the most out-of-hospital births occur in North Rhine-Westphalia, Bavaria, and Baden-Württemberg. Those are also the biggest federal states. We have a register for that. All midwives working independent and providing home births or birth center births have to document their birth. The birth of the women, or if they had to transfer them to a hospital. So there we have relatively accurate numbers, and the publication is once a year, so that's a very fresh publication from summer 25 with the numbers of 24. So I will give over to my colleagues.
So we have the classic hospital-based midwife working with colleagues and working together with obstetricians. It's protected by law that every birth has to be accompanied by a midwife. But we have to take obstetricians into the delivery room when there are any risks. This is the side of the law. But because of hospital hierarchies, the obstetricians are mostly involved, except in midwife-led units. We are working together with other midwives on shift, with the obstetricians, with the nurses, only in the case we transfer people from the labor ward to the maternity ward, and in case of emergencies we work together with pediatricians. Out of the hospital in antenatal and postnatal care, we are mostly alone. There are collaborations between midwives or offices with more midwives, but we are mostly alone, and we can just work with midwife friends, or if we are connected. We send people in case of risks, emergencies to hospitals, pediatricians, obstetricians. We have several lactation consultants, but lactation counseling is part of the midwifery work and covered by insurance when it's done by a midwife during the scope of practice. And in case of danger for child safety, we collaborate with early childhood intervention teams. So, finance is, this is the easy part. When we have a hospital-based midwife, which is employed at the hospital, she will get her salary from the hospital, has to pay taxes, several insurances, and the hospital is reimbursed via insurance companies, or in case of private insurance, the hospital will bill the family. Community-based midwives, it's like a fruit salad.
So easy.
We will go through it, because it's really this complicated even for the midwives. When you're new in this profession, it's really challenging. So, in case the a pregnant woman is in the public health system, she does have to sign a contract between the midwife and the woman about the amount of care she needs. Yeah, we can provide care from the beginning of the pregnancy, during pregnancy, until she stops breastfeeding, or if she doesn't breastfeed so long, until 9 months postpartum. In case of public health insurance, I as a midwife will bill the insurance and they will reimburse. I have to pay taxes, many insurances, and everything else. In case she is in the private health insurance, she has to pay me first, so I will send bills, she has to pay me, she will get reimbursed. And we have other financial help from the government. When you're doing home birth, the insurance for the midwife is really, really high. It's up to 15,000 euro per year. And you don't get as much money for a home birth. You also have to pay this high amount of money when you are doing midwifery in a hospital, but self-employed, a very Bavarian problem. And then you get about 100 euro per birth, but you have to pay 15,000 euro a year to be allowed to work. So the government tries to help. Yeah, you pay the insurance first and they will reimburse you after the year about 80 to 90% of the amount. Yeah. No. So normally people don't have to pay for maternity care at all. But there are possibilities for midwives if they think they need additional types of care which is not covered by insurance, they can bill people. And we are, even if we are self-employed, we don't make our prices. This is one of the problems, so we are regulated. It's called the Hebammenhilfevertrag. They tell us, okay, everything you do has this work. There was a big change on November 1st, and now we are paid by our time. And it's really big discussions in the midwife community, because there were people working really efficient and fast, and now they have to work more or longer for the same amount of money. It doesn't matter if you have a bachelor's degree, a master's degree, lactation counseling experience, because you always get the same amount of money for your work when you work with women. It's only in case you work at the university as a teacher. We are regulated. There is the Midwifery Act where it's regulated what you have to learn during your studies. And we work on a professional code of conduct. And we are also protected by these laws, because it's protected that deliveries are accompanied by doctors or midwives, but every doctor, obstetrician, has to make sure that he calls a midwife to the delivery. Midwives, in case of low-risk birth, they are allowed to do it alone. It's just the hospital system which makes a little problem. And, in case of any risk, complications, we have to make sure that the women that's also take the care of obstetricians or retired from pediatricians.
Yes, I was just talking that we have problems in Germany, perhaps you heard of them, the Hebammenhilfevertrag, which was now newly set up from the 1st of November. And there was a rather small research from Opta Data. They asked 800 midwives, and there were in all newspapers because one of the results was that 44% of those midwives said, I don't know if I want to go on working as a midwife, and I have the feeling I will leave the profession if our situation won't get better. So I was just thinking with Canada, and it's always the thing, it's burnout, it's too little money, it's too much work or too high workload. So we have to look with caution at those results, because it's only 800 midwives from 28,000 were asked, but I think it should be an alarming signal also for politicians to say, wow, we have to change something in our health system. And I think that's a topic all of us have to deal with in midwifery. In Germany, it's a very dynamic situation. Since 2020, the vocational midwifery education, we were the last country in Europe, has gone up to academization and universities or universities of applied sciences. We have, you have to think of that, in 5 years we have 47 direct entry bachelor programs nationwide, and approximately 1,500 midwifery students start their study program per year. So I believe we won't have a problem with the workforce or too little midwives in the future, but we have not enough of academic midwives to fill in the positions at the universities. So we were just looking around, we have about 57 midwifery professors in Germany now who did their PhD, and we have from the German Society of Midwifery Science, we have now a little group, a working group, and we saw we have about 45 midwives in the process of PhD. So I'm happy. As I was saying, I'm not the youngest anymore, so I have the feeling, wow, when I retire, there will be a new generation after us. But nowadays, it's really difficult to, when a professorship is announced, we have 2 or 3 universities where obstetricians took over the professorship of midwifery, and that's a big discussion in our very young discipline of midwifery science in Germany. Nothing against obstetricians, I just want to say, but it's when we are in our development of a discipline, in the professionalization, it's absolutely, that we have to do that. Our bachelor program is 7 to 8 semester, and in those programs it's 2,200 hours of practice minimum. Mostly it's about 2,500. We have master programs starting in about, I would say, 5 to 6 universities, and we are starting also with the masters on advanced midwifery practice. We have very little positions. I know of 2 in the whole of Germany, and that's also the work of creating these kind of positions and talking to hospitals about those positions, because the hospital will have to finance them. Our educational system is state-run, so the midwifery students don't have to pay any study fee, and they get paid per month about 1,300 to 1,500 euros. That is rather new. Long ago they would have to finance themselves, and now they get paid. So that we have the feeling that's why a lot of young women, I say women, we only have in Germany about 30 male midwives from the 28,000. I didn't think how many percent that was. And in the master's programs, we are starting to build this up, because midwives or academic midwives went into nursing science or pedagogic or whatever, social sciences, and now we are trying to stay in our profession. And we have starting PhD and doctoral programs. Ongoing professional working is very different in 16 different federal states. That's in Germany, I would say, a challenge. For example, in North Rhine-Westphalia, where Cologne is one of the cities, midwives have to prove all 3 years that they had 60 hours of ongoing practical learning. 20 hours of that have to be emergency hours. But other federal states don't have that. That was our question before on our topic, no national registration of midwives, so it's difficult really to get the numbers and to see if the numbers of midwives are sufficient in providing care for the women in Germany. And specialization is under construction, I would say. That's our scope of practice, and you see family planning right on the left. It isn't paid as yet, but midwives counsel with family planning, pregnancy, as Anna was saying, labor and birth, postnatal period. The health insurance pays for at least 12 weeks of home visits of midwives. They can do that up to 26 times, and also in the breastfeeding phase. And we have family health midwives. They work with the families, vulnerable families, until the first birthday, or at least sometimes also until the third birthday of the child. So I would say postnatal phase is rarely covered fine, but only about 50 to 60% of the women, or the women who gave birth in Germany, have a midwife. That's due to not enough workforce, or they are not informed that they have the opportunity to have a midwife. And mostly that are women from different countries who don't speak German perhaps, or women with, I would say, issues in the socio-economic way. So that's also a big challenge to inform all the women. Primary care, we were discussing that in the train yesterday. Yes, actually, midwives could work as primary caregivers, but the system doesn't allow it in every part of our scope of practice. You were saying that independently, low-risk clients can be looked after by midwives, but also interprofessional, and medium and high risk. I don't like the term risk, but medium and high risk women are looked after by two professions, so the midwives and the doctors. And as we were saying, hospitals, freestanding birth centers, midwife-led units, it's a growing number. I finished my PhD 2010. We had 4 midwife-led units, okay, in 5 minutes. And nowadays we have around about 60. Legally, midwives always hold responsibility for their actions wherever they work, hospital, out of hospital, but according to hierarchical structures in the hospital, this differs. And there's no law, but it's the organization in the different hospitals, what kind of head obstetrician is there, what kind of head midwife or senior midwife, and what do they work out together, how to work together. And now Anna is going to show you one more slide to confuse you more.
Yes. The 3 types of hospital-based midwives in Germany. The classic one, it's employed by the hospital and paid by the hospital. Then a very Bavarian specialty is the Dienstbeleghebamme. She is not employee of the hospital. She is self-employed, but she works in the hospital, organized in a team, and is on duty several days a week, but is paid directly from the insurance of the woman and not from the hospital. And another thing, I don't know how it goes, it's the system of Begleitbeleghebamme. It's some kind of bring your own laboring woman with you to work to the hospital. Yeah, you are on call for these persons, and they have insurance of the woman will pay you, and in most cases they have to pay an extra fee because you are living on call for about 5 weeks for this person. And when she goes into labor, she calls you, and you go with her to the hospital. You have a contract with the hospital and take care of her.
I think that's a kind of all over the world we have the same responsibilities, or our core responsibilities are to provide a respectful, woman-centered care, look after the physical health of mother and child, and also the well-being, and that is sometimes it's forgotten. And we have a code of ethics. We are very near to the ICM code of ethics and also the competencies. Midwives have the autonomy. We want to work with respect. We want to empower women. The dignity is a very big issue. 25th of November is always the Obstetric Violence Day and being with women. And we don't have I would say, the valuation of midwives' expertise, no official assessment of expertise. It's with your working experience you would get a higher pay. And our maternity care models, we were talking about that. When is there continuity of care? And then we see that in the out of hospital, in the birth centers where teams, like caseload teams, look after the pregnant women, the birthing women, and the in the postnatal phase, and also as the Begleitbeleghebamme who takes the woman with her. And in the clinical setting, it's not always feasible, but it's legally required. We collaborate, we were showing that in the picture, with several other health care workers. And the hierarchy is sometimes difficult, except in midwife-led units where midwives also have hierarchy, but the same profession. And the agreements on collaboration as mostly informal, and in hospitals there will be organizational agreements. And are there discussions or conflicts regarding hierarchy? Yes. So that's a topic I think we all have to deal with. So thank you for your for listening. I'm happy to answer questions.
Fantastic, thank you very much. So, yes, shall I go first? Yeah. We had two questions, but one was already answered in the chat.
Okay.
But we have also a question from Tamar from Haan, and she asks, do the funding system and regulations for midwives vary across the different Bundesländer?
You want to answer?
No, it's in whole Germany. It's just that several Bundesländer or city have a small extra bonus when you are new and you open up a midwifery practice, and you get 1,000 euro to cover the bed.
So there are not a very large difference between.
No, there's only the difference between the private patients. They have different regulations in the federal states. Private patients, you can sometimes get the double amount. So that differs in the federal states. But the contract or the Hebammenhilfevertrag is for the whole of Germany nationwide.
Okay, well, thank you. That was for online.
That was it? Yeah. No other questions? You were very clear then.
Yeah.
Any questions here?
My name is Esma, I'm from Holland. I have a question. You said just now the salary is based on experience of the midwife, but how does that work if you don't have a midwife registration in terms of quality?
Okay, thank you for the question. I was a little bit unclear. It's for the midwives who work in hospitals. So if you start working, we just had a pay rise in the hospitals. You get, it's called P11, I would say, and I was saying it doesn't matter if you are a vocational trained midwife or a bachelor midwife, that's also a discussion. We don't have a pay rise for master midwives as yet, so that's a big discussion. But when you start in the first year, you have a certain amount of salary, and when you get into the second and third year, you will go higher. So but you are completely right. In the independent midwife always earns the same money if she was working for 20 years or in her first year. And bachelor midwives are allowed to go into the practice straight away after 7 or 8 semesters.
Raises are only in this model.
Yeah.
Any other questions?
Are there rules for continuous education for the midwives?
Yeah. You want to ask?
We have to do reanimation.
Emergency
training And it's different in the Bundesländer, as it depends from the region where you live. It's about 30 to 40 hours of training in 3 years. But it can be emergency training, it can be lactation counseling, some news and documentation, it varies.
And is it the same for all hospitals, or does it also vary the way you are employed by the hospital?
No, all midwives in Germany, if you work in a hospital or you're an independent midwife. Also, I as a professor have to do that. So that's quite good. I say, okay, I had this lecture last week, but sure, I will go to the seminar of somebody else. But that's fine with me. It's great to get in contact. And there's one new regulation we have in our new system of education. We have mentors. The midwifery students have to be mentored when they're in their practical placement 25% of this time. And those mentors have to go do 24 hours a year on pedagogic, on counseling of midwifery students and so on. And they have to have an ongoing education of 300 hours at the start and then 24 hours per year. So to guarantee they're on the newest level and can look after the midwifery students in an adequate way.
Thank you for your presentation. Did you say that the Bachelor of Midwifery students are paid?
Yes.
But it's new. When I was a student, I had to go to university, to the hospital and other practice, or to the independent midwife, and I was in a bakery at the library of the university, and I worked for my professor. Yeah.
So I would say that is really it's great because we have the feeling the midwifery student can really focus on learning, and it's also good for midwifery students who have family already. You know that we have a different range on ages now. When I look at our program, we have the very young students come in directly from Abitur, from their, I don't know how it's called, secondary school, and we have somebody mid-30 with 2 children who says, oh, after I gave birth, I know how important midwives are and I would like to become one. And that's really, I think that's a very great opportunity for us. And it was a long way of fighting for that. We were doing this 2017 to 2020 with a lot of political work together with the Association of German Midwives. And it's great.
So just in Australia, they're bringing in some prac payments, so students will get paid when they're on prac, but it's very hard to get it. You can't be married and have a husband that earns money, then you move out. You can't have a job in the shoe shop, you can't do anything else. And then the other thing is, do the students have to pay fees for their education?
No.
It's free education.
It's free. If you go to a private university, there are very little in Germany. If you are at a state-funded university, you pay per semester, it's called semester fee, and you get about 300 euros, but once in a half year. But you don't have to pay for your education. Only if you would be in a private university, then you have to pay about 500 euros per month.
In Australia, they pay about 15,000 euros, so $30,000.
Wow.
Yeah. For their degree.
Wow.
Yeah, that as well. Yeah.
And still,
they get a loan.
Yeah, and still a lot of you will have a lot of applicants. You see how the wish to become a midwife is great, but I think it's kind of brought in more diversity in our study programs with the payment of the students.
Thank you.
Thank you.
You have to be Thank you, great again, and you're all doing so well for keeping time. We are right on time to go for lunch. So, as we discussed before, all of us here in the room, let's go there to take a picture. And let's be back sharp at 1:30.
get you out. You can get everybody on that.
Be like, by the way, we're doing an RCT.
Jeg tenkte kanskje jeg skulle se for da kan jeg liksom se på den. Og se på stålhånden.
It's like it hasn't even gotten on the bus to school yet.
Thank you. I'll have to read through the set. I can still have some after I've done it, so I can check it off. Yeah. It's a good time on the list.
It's just gonna stay right here though. I'm not supposed to send it. Just a little bit.
Yeah, maybe.
I don't even know if it's available every time. Do you know what they are?
Okay. Are we all ready to start again? Oh, yes. I really hope you enjoyed your lunch and that we can beat the after lunch dip. I'm sure we can with an exciting speech from Norway, given by Hilde Christensen. I could leave out the middle name, I was just being told, and Enid Mure. And Hilde is a midwife with 12 years of clinical experience. She has worked in both midwife-led units and obstetric departments, as well as in community health centers, primarily in Oslo. In August, she transitioned into academia and is now beginning her career as a lecturer. She will be joined by Enid, who is also a midwife with clinical experience in hospital maternity care since 2011. She completed her PhD in 2023 and now works as an associate professor at the University of Southeastern Norway. Please, the floor is yours.
Thank you so much for the introduction, and thank you for this wonderful lunch, and thank you for having us here. It's a pleasure being here with so many great colleagues. Before we go into the numbers and the things that we've been asked to talk about, we want to start with a little story or setting the scene by telling a little bit about the challenges that we have in Norway, which ends with a little question that you can have in mind while we do our presentation.
Yes. There are many ways to engage you in understanding what everyday life looks like for midwives in Norway and the challenge we currently face. We could have chosen to highlight the debate around free birth, which gained momentum in early spring 2023. Statistics shows that in 2024, Norway had 21 free births without healthcare professional present, an increase from an estimated 20 over the 3-year period from 2020 to 2023. Unfortunately, there have been tragic incidents where babies did not survive and likely would have if healthcare professionals has been present. This has also sparked further debate about the role and competence of doulas. At the first time, the response to these women was criticism, that they were taking great risks, were irresponsible, and didn't know what was best for themselves or the babies. But the debate had shifted in a way. Now, the focus is more on what it is about the publicly funded and universally accessible maternity care system that leads some women to choose free birth. Norway recently held parliamentary election, and maternity care was certainly one of the topics discussed. It's impossible not to live in Norway and not have noticed the debate. Media coverage frequent, with women sharing difficult and traumatic birth experience. Even politicians have shared their own stories, emphasizing the importance of safety and individual care. At the same time, Norway is facing a growing shortage of midwives, and many maternity wards are struggling with staffing and retention. This has become a major concern both for professionals and for women giving birth. 3 of my colleagues at the hospital where I worked for many years recently published a powerful opinion piece in a national newspaper. I want to share parts of it with you, and it describes well the situation in Norway, I think. Where new life begins, our is torn apart. We are proud of our work, but we are also exhausted. Many of us are considering leaving, some already have. We stand in life's most intense moments where safety, presence, and professional competence are crucial. Our work is growing in complexity. When we meet a newly graduated midwife who has worked 1 year in a maternity ward, she describes her daily work as filled with new life and family's most significant moments. She is dedicated and wants to give women and their partners a safe and positive experience. But the responsibility is enormous, and she often feels fear, loneliness, and a sense of not being enough. Education prepares midwives for what it's like to have 10 years of experience, while she wonders how she will survive the first 3. The transition from school to clinical practice is a shock. The need of guidance after difficult shifts and emergencies is great, but opportunities for reflection, professional discussion, and debriefing are lacking. If you are lucky, a colleague might take time to talk after work. There is a growing disconnect between the ideal and the reality, between the midwife we want to be and the one we are forced to become. This text captures the tension many midwives in Norway feel today. And it leads us to a central question. You don't need to answer it, but you can have it in mind. No, that's okay. But the question is there truly a shortage of midwives in Norway? Or is the challenge more about how the maternity care is organized?
And we don't expect anyone to answer this question right now. We will come back to it by the end of the talk, and you can just have it in mind while we go through some of the key characteristics of Norway. So, Norway has a population of about 5.6 million people. And one thing that makes us different than a lot of other countries in Europe is the population density. We've heard from Canada today, so we understand that it's not that low in a global setting, but in Europe it's very low. We have about 54,000 births per year, and the average number of children is 1.44. This is a small rise from the year before, but it's still historically low in a Norwegian context. On the other side of the slides, you see the midwifery force. In Norway, we think we have around 6,700 midwives with authorization. But this is the midwives that are working in midwifery positions. There are about 3,000 midwives actively employed. Around 700 of them work in the communities, 1,900 work hospital-based, and the remaining 360 work in private sector or other ways of working with midwifery. It is also worth noting that these numbers of midwifery, there are higher numbers of midwifery positions than this, and that is because, like Hilde said, we're struggling with retention and staffing, and there are some midwifery positions that are filled with nurses right now. In Norway, birth care is organized at 3 levels. We have midwife-led units, maternity wards, and obstetric departments. The midwife-led units are divided into alongside units, which are located inside hospitals but run entirely by midwives, and freestanding units, which are outside of hospitals, often in rural areas, and they have agreements for referral and emergency transfer. As you can see on the map, here this map seems so small, but it is kind of a big country. So the distances are bigger than it appears on the map. And they are spread out across a large geographical area, and especially in the north and in the inlands, the distances are quite far. And this is a result of the low population density that we talked about. Okay. So community-based midwives, they mostly collaborate with other midwives in the same service. When complications arise, they refer women to the hospital, and after birth, care of the baby and the family is transferred to public health nurses, and the community midwives also work closely with GPs or family doctors that are assigned to every citizen of Norway. And often the midwives also collaborate with the hospital and obstetricians in the hospital and the midwives for transfers and things. Private midwives who attend home births in Norway have a similar pattern than the community-based midwives. And the hospital-based midwives works in teams with other midwives, maternity care assistants, obstetricians and nurses, and they collaborate with the community midwives after discharge. So to this graph, I think everyone has been finding it challenging to make this, but I will try to explain how we do it in Norway. So the hospital is financed through taxes in Norway. It's a combination of fixed budget and activity-based payments. And from these payments, the hospital pay all operating costs, including the salary to the midwife. For the women giving birth, this means that the hospital birth is completely free. And what we try to illustrate by having this white line here is that giving birth and having this free access doesn't require the women to pay taxes herself. As long as she's a citizen in Norway and a member of the national insurance scheme, which everyone is, everything is free. And what we try to illustrate here is that there's no private insurance or anything required. And this public funding model also covers how the midwives in the community works. They are paid employees of the municipalities. And then, since the system in Norway is a bit different than some of the other countries here, we've used this slide that I couldn't change the heading, so it says community-based midwifery, but this slide actually shows how home births with private midwives are funded in Norway. This is because in Norway, the community midwives mainly provide antenatal and postnatal care, and they do not normally attend births outside the hospital. Home births in Norway are not part of the ordinary public health system, and it's offered by self-employed midwives working independently. So the family has to pay the midwife directly out of her own pocket, and after birth she can apply for a small reimbursement, about 10% of what she pays, I think, she can get back. So the line from the women to the midwife indicates that she is paying for the income of the midwife. And this up to insurance implies that the midwives have to themselves pay for insurance to the National Patient Injury Compensation Schemes, which act like an insurance if something happens to the women. It's worth noting that recently the regional health trust have been giving the option to finance home births, but as of now there's no obligation for them to do so, so no one has chosen to do so yet. So for now, home births are privately funded, and in many parts of Norway, because as you see on the stretched out map, is not available at all because there are no midwives offering it. So to the education in Norway. Midwifery education in Norway is part of the public higher education system, and it's offered at 6 university and university colleges. Norway does not have a direct entry program. To become a midwife, they have to be registered nurses, have a bachelor's degree in nursing first, and have at least 1 year of clinical experience as a nurse. And only then they can enter a 2 years master's in midwifery. Continuing professional development is not legally required in Norway, but it's strongly encouraged. And most midwives take part in courses organized by the employers or other courses or seminars. Sometimes they're funded, sometimes they have to be self-financed. And some midwives go on to specialize, for example, in ultrasound, fetal medicine, public health, leadership, or move into teaching and research, including PhD studies. Then it's over to you.
So, midwives hold independent responsibility and autonomy for low-risk pregnancies, births, and the postpartum period. The responsibility also includes identifying risk factors and assessing the need of specialized expertise. Midwives are responsible for the continuous selection between low risk and high risk. The criteria for this selection are outlined in national guidelines and legislations. During pregnancy, this means referring and collaborating with the woman's GP, and when needed, referring and directly to an obstetrician in hospital. If the woman is healthy and the pregnancy is progressing normally, she may receive follow-up care only from a midwife. It is the same during birth and postpartum ward, even when the birth takes place in a hospital. If risk factors are present from the outset or arise during birth or during labor, the midwife collaborates with an obstetrician who then assumes the formal responsibility. Postpartum wards are often divided into low risk and high risk units. In obstetric departments, it is normal to have hospital-hotel units for postnatal care. The stay after birth is typically lasting 2 days. The formal examination of the newborn is carried out by a pediatrician on day 1 or 2, not by a midwife. All women have the right to have a home visit by a midwife within 1 to 3 days after returning home. However, in many parts of Norway, this is not implemented, often due to a shortage of midwives. It is also recommended that women have a 6-week postpartum checkup, and this can be performed by a midwife, not just a GP. The midwife can provide contraception, insert devices like IUDs or implants, and take cervical smears. This is voluntary, and the woman must take initiative herself. So the system is generally inconsistent and has received criticism for this. Since midwives are authorized to prescribe contraception to women aged 16 and older, and their board competence in women's health, many are involved in adolescent health centers in the community. Midwives mainly work in the public healthcare system with limited private practice due to strong public services. Private midwifery is mostly found in larger cities, often focused on ultrasound, and many combine it with public work. A few small businesses offer home birth services, usually run by idealistic midwives and not part of the public system, as Annie told. Midwives have historically enjoyed a high level of trust, and this remains true today. Midwives are generally met with great respect for their work. The profession is associated with warm safety care, high-level competence and knowledge, and I will say loving care. most women wish to receive care from a midwife. Midwives have an important role to advocating for normal birth process. During pregnancy, some women receive little or no follow-up from midwives, often due to a shortage of midwives rather than by choice. During birth, national guidelines highlight the importance of one-to-one care from midwife once the woman is in active labor, specifically after the cervix has dilated to 7 centimeters. I believe we still reach this goal, but we are seeing an increasingly pressured healthcare system which challenges the ability to provide one-to-one care. Midwifery is characterized by values such as respect for women's autonomy, continuity of care, and a woman-centered approach. Midwives play a crucial role in early identification of vulnerability and asking women about the experience of violence. This is also highlighted in national guidelines, which emphasize the midwife's important role. However, we are increasingly noticing a reduction in trust toward midwives and the broader healthcare system. More women are questioning the care, and some refuse examination and treatments. We are also noticing increase of fear of childbirth, and women are uncertain about the quality of care they receive. Today, 30% of all births are induced, and the rate is consistent across the country. We have a C-section rate of 16%, which is low, but all type of intervention is becoming more frequent. This may affect trust in maternity care and may impact on midwives' ability to practice professionally. This can also be some of the reason why we are unable to fill vacant positions. In national guidelines, it is highlighted that maternity care should be comprehensive and promote continuity. There are differences in how this is practicing. In rural areas, where there are significant distance to obstetric departments, it is crucial that women are correctly assessed to minimize risk. This is normally done at week 36 of pregnancy. In large cities, this assessment is not carried out as systematically, since almost all births take place at obstetric departments. I'm most familiar with the Oslo area, where we previously had a midwife-led unit part of the hospital. This unit was closed in March 2023. This means that women in Oslo now only have the option to give birth at obstetric departments, or alternatively choose to a home birth with a private midwife, which involves a significant out-of-pocket cost. On the other hand, women in rural areas may not freely choose to give birth at obstetric departments, unless they are referred there. While they can opt to travel on their own initiative, but the cost of travel is only covered if they have been selected for birth at higher level of care. In the community, women often see the same midwife before and after birth, but in hospitals, this means they meet new ones. Hospital care is typically fragmented. Women first meet midwives in admissions, then in the delivery room, and finally in postnatal wards, which often have nurses instead of midwives due to staffing shortage. Smaller hospitals tend to have more integrated units, allowing midwives to provide continuous care throughout the stay. We have not traditionally had caseload models in Norway, but in spring this year, a pilot project was started in a mid-sized city, Drammen. This project is being followed with great interest by professionals, politicians, and national leaders to assess whether this could be a better way to organize care. Many advocates for home births to be free of charge and included as part of the public system. There are also pilot projects involving combination position for midwives between hospital and community, aiming to better facilitate this type of work and also to help retain midwives in the hospital setting. Norway has a relative flat hierarchy, and midwives collaborate overall well with other professionals. Historically, the healthcare system has been dominated by doctors, and we still see that doctors remain the most represented professional group. When guidelines are developed, midwives are generally underrepresented, and obstetricians tend to have the greatest influence. But we see some positive change. Around 3 years ago, Norway established the position of Chief Midwifery Officer to strengthen midwives' role in public health, a development that is positive. Also, the fact that midwifery is now a master's level profession may help make the midwifery voice more visible. On the other hand, the reduction in midwife-led units may reduce opportunities for autonomous practice among midwives. In the community settings, the main challenge is more closely related to public health nurses. And the fact that locally and not nationally, as far as I know, it has been decided, or more a tradition, that only public health nurses can occupy leadership roles. Things have started to change, but there are still progresses to be made. So, we hope you remember our opening question. And
if not, we can have it here.
No.
Oh, yeah.
Yeah, we can.
Yeah, it comes back on later.
And that we have provide useful insight to our country. Although we often say that Norway is one of the safest countries in the world to give birth, with very low mortality rates, we still face challenge. Many women experience a lack of continuity and respectful care. And in addition, Norway's large geographical distance and sparse population make it difficult to ensure equal maternity care across the country. So, we still have time, or?
Yeah,
it's
you're actually almost finished, but if you just round it.
Some lines?
Sorry?
Yeah, I can say something more.
If you finish it off now, that's fine.
Yeah, okay, I soon finished. But Norway is conducting a national survey on women's experience with maternity care. While data from spring and summer births are still pending, early results published just some weeks ago show that 8 in 10 women are satisfied. Postnatal care score lowest at 72%, while community midwife care during pregnancy score highest at 91%. The survey has already sparked debate, particularly around postnatal care, system gaps, and its limitations. Many think it doesn't fully reflect the complexity of the birth experience and doesn't tell the whole story. Nevertheless, we hope, of course, this survey will contribute to the improvement of maternity care. So, thank you.
before we open for questions, we just want to thank the Norwegian midwifery societies for helping us with this. And here are the questions again, if you don't remember.
Oh yes. And I think you get the answers now from you?
Yeah.
Oh, no, you have the answers. Oh, okay. Never mind.
We'll
I think the questions from the chat first.
Yeah.
If you want to say something about this question?
We can take the questions, and if someone has something to say about this, we'll...
Okay. Go for the
Yeah, we have two questions actually. So the first one is from Tamar van Halen. And she asked, are there multidisciplinary agreements about risk assessment? As in, is there consensus about the indicators for medium or high risk care?
That was very difficult. I think we have guidelines that should prove that we are doing the same, but I think we also have a lot of difference around the country and in different cultures in the hospital settings and in the community also how this is actually practicing.
Okay.
So yeah, both yes and no.
Okay. Yeah, there is, but only in the region. And if you are living in the next region, the rules can be very different.
Yes, but
we have both national guidelines and local guidelines, and the local guidelines should adhere to the national guidelines.
Of course.
But as we know, this is depending on persons always.
Yeah. This is the problem.
And also can be a little bit different in the hospital.
Okay.
But not everyone follows the national guidelines. Make their own.
Yeah, thank you so much.
All both of you.
Yeah,
because of the microphones.
Yeah.
Sorry.
Okay, here.
Yes, the other question was about ultrasound care performed by midwives. And the question was, is ultrasound routinely used by midwives when inserting an intrauterine device? And is this included in the basic education?
Yeah.
So I think it's also about, do midwives provide ultrasound care? Is it in the basic education, for example, also when providing for?
Then we have a special school or education for ultrasound for 1 year after midwifery. So then you have to have a license or education to do it.
Yeah.
But
Yeah,
so not for everyone.
Yeah. So it's not within the education. It's,
no, it's not part of it.
Yeah.
But we only do ultrasound in 2 times during pregnancy in the system. So it's.
So what are the times when they use it? When do you do it? The 2 times.
It's in the hospital with the midwives.
Yeah. So in the beginning of pregnancies, that was mean, and then
in
week 12 and week 18, 19,
and 18.
And the other ones are on indication, for example.
Yes, correctly. Yeah. But then only. It's not ultrasound in the community, it's just in the hospitals.
Also in the hospital.
Yeah.
Okay. Yeah.
And in addition, a lot of private midwives or private offers it.
The private midwives also offer.
They can offer ultrasound as well, yeah.
Okay.
If they want it, if the women want it on the basis that they're not referred to the hospital, just to see.
Yeah, and then they okay. Thank you. Those were the questions.
Yeah,
thank you.
Yeah, we're going to see if you can find the answers on this. In the meantime, any questions from the audience? Yeah, Nicola?
It's not really a question. I was thinking about your question, and I would say you're saying you have 3,000 midwives, right?
Actively working 3,000. Yeah.
3,000 to 54,000 births. I thought that's a quite good code, but I really believe how you were saying that some midwifery units have to close, or the midwives are perhaps overwhelmed and overworked. That could be the problem, and perhaps you need more midwives. That all midwives don't have to work too much and get more money.
But I repeat this for the people at home, because I understood that online we can't hear so well. So what you're saying is you're a bit in a way surprised. There are 3,000 practicing midwives, 4,000 births. So the ratio is So
54,000.
54,000, sorry. So the ratio doesn't look that bad to you, but maybe it's because many midwives are burnt out, you need more midwives to cover that. Yeah?
Yeah, thank you.
Yeah.
Continue.
No, it's fine.
Oh, okay, that was it. Well, linked to that, I was thinking, because you do the whole women's health, you do contraception, you do youth services. Is there any discussion on, now that there's such a shortage of midwives, to maybe limit the scope of practice a little bit? Because I think the contraception care could also be done by nurses, maybe.
Absolutely, but it's been a hard fight for us to get that. We feel that that's really within our scope of practice. We don't want to lose that now. No, I think I believe that that's really within our scope of practice. So
I think it's important for me to keep it, but I think we have to see on the system and have some changes, because I also registered that we actually have a lot of midwives compared to compared to the other countries here. So
and we also have, like, the numbers are, because there are more registered midwives than the ones working, a lot more actually. So they're out there.
Yeah, exactly. Well, we got some answers here. Maybe first, what people thought about this question?
Yeah, they had the first question, so is there truly a shortage of midwives? So we had 14 answers for yes and 5 answers for no.
You think there is a shortage of midwives? Nobody did the calculations as well as Nicola. Well, what do you think then about this?
Obviously there is, because when there are available positions in the hospitals, they don't get enough applicants. So there seems to be a shortage, but it depends on how you look at it, I suppose.
I think also some of the problem is we have the same system for everyone, and also for the midwives. It's not we have to work in a very special way, but we want maybe to work differently, or also more with home birth or with more low risk. But now we are forced to be in the obstetric units, and I think that's difficult for many midwives. And then we leave and do other things.
So it's a bit like in Canada, I think, where you have to do, if you're a midwife, you have to do the full scope, and you can't have variations in how you practice. Might be an interesting topic to discuss further, where we can compare the systems. Thank you very much. Right. Now we go to another neighboring country for Holland, at least. That's Belgium. And we're going to listen to Katrien Beekman and Valerie Bijkmans. Professor Katrien Beekman is a midwife and holds a master's degree in health promotion and a PhD in social health sciences. She's responsible for the Nursing and Midwifery Research Group, affiliated with the University Hospital and the Free University in Brussels. Her work focuses on the organization and implementation of care models in perinatal care. She's the coordinator of Born in Belgium Professionals and Group Care Belgium. And as a member of the management team in clinical practice, she is aiming to stimulate innovation and research in advanced nursing and midwifery roles. Now, she will be speaking together with Valerie Bijkmans, who is a trained midwife with a master's degree in management and organization of healthcare. After working several years as a midwife and head midwife in the delivery ward at the University Hospital in Brussels, she now works there as the manager of the Mother and Child unit. And in addition, she is the vice chair of the Flemish Association of Midwives and is actively involved in the organization of perinatal care in Belgium. Combining clinical experience with policy expertise, she is committed to high quality and integrated midwifery care. So let us hear more about it.
Hello, everyone. Okay, for starters, we have a question for the people following from home or online. What do you think? How many pregnancies, low-risk pregnancies in Belgium, are being followed in a midwifery-led care model? I think you can think about it afterwards when we finish. Katrien will discuss a little bit the answer with us. For Belgium, we're not a big country, a rather small country. We have almost 12 million people, and the births are at 108,000 per year, but they are dropping really quickly at the moment. The average number of children per woman is 1.47 at the moment. I see there went something wrong with the color of the dots, but I'm going to explain you. So for more than 80%, the midwives who work in Belgium are working in hospital-based setting, and they are employed and paid by the hospital itself. We have 639 from the 8,230 that are working only in the independent care community based out of the hospitals. And in Belgium, we also have almost 10% of midwives who are doing both. So part of their time they are working in the system hospital-based, paid and employed by the hospital, and for the other time they are independent and they are working for their own. We have quite a lot of hospitals in Belgium for the range of our little country. We have 139 general hospitals, with 42 general hospitals with a university character. And we've got 14 hospitals with a university hospitals. What does that mean? The 14 university hospitals, they have to care for people, educate, and also the science, to do the science themselves. And for the general hospitals with the university character, they also do one or more from the teaching and the scientific program. The teaching is more for doctors than for midwives, because every general hospital in Belgium also allows midwives to come to the hospital to get their training in the hospital wards, but the places are limited because they are limited. This one I'm going to skip because Katrien is going to take it. But for the financing system, we try to make it as simple as possible, because in Belgium everything is a little bit complicated. But here I think we did a good job to try to make it a little bit clarified. So we have the women, we have the national security insurance. The government has its agreements and also pays a lot to the general public insurance. Then we have the hospitals on the other side. We have care for women in the hospitals. A part of the care is paid by the social insurance. And a part is also paid by the women themselves, by cash flow, or if they have a private insurance, there are parts or the total amount that is extra that is being paid by the private insurance. Every midwife who works in a hospital in Belgium gets her income from the hospital itself. For the independent working midwives, it's a little bit different, because there is no hospital. There is also no other thing that it's arranging. So she works fee for prestation. So the social insurance pays for the things she does. It's for the prestation she does. And she can also demand extras from the private insurance or from the women themselves. The context is a little bit complicated. We have a federal government that's central, but we have also 3 language-based communities and 3 regions. So, for example, that makes that we have 9 ministries of healthcare. Yeah, for the really small country that we are, and they all have to be on the same page before we can change something on the total level of Belgium, or they can go their own way on a smaller topic, and therefore we sometimes have total different systems in the north of Belgium than in the south of Belgium. We have a mandatory social health insurance system that's characterized by the independent medical practice. You can choose where you go as a patient, but also the healthcare professional can choose if and how we treat the patient that come to us. We have a direct entrance, so you don't have to be referred to somewhere, or you don't get referred to somewhere if it's not necessary. We have a fee for service. So it's really the prestation, the act that is you getting paid. And we have both public and private institutions, and they are both reimbursement on the same way. We have federal and the federal entities in our healthcare, and they all have other things they can arrange. The access to the profession of midwife is arranged at federal level, so for whole Belgium. The educational regulations, so the education for our midwives depends on the regions, so it also differs from the north to the south. Prevention and primary care is also regional, and we have there also big difference in between the regions. Hospital care, some things about hospital care is federal and other things are regional. For example, the planning of hospital beds and maternity care beds, it's federal, but if you want to build a new hospital as a hospital, you have to go to the region to ask funding, to check if your architecture is in the right way and things like that. And the reimbursement system is federal, and that's the same for all our country. The financing for the midwives, like I said, fee for service or fee for prestation. We have regulations regarding the duration of visits and other things, but that's in case you follow the regulations. It's not necessary to follow the regulations. It's a choice you make every year if you're going to follow or not going to follow the financing regulations that are there. Reimbursement is by the National Health Insurance System, and until 2026, so at the moment now, there for the midwives that follow the regulations, there are no extras for the patients to pay. So midwifery care was free until 26, but now just some weeks ago, the government agreed that we are going to start with asking extras in the regulation that are there now. So that's something new with pros and contras for both. The midwives who work in the hospitals, they have a fixed salary. The hospital earns money mostly through national financing, and if the midwife in the hospital also does primary care, like consultations, they also get a small amount from the fee for service, what is called in Flemish nomenclature. In community health centers, which exist in Belgium, but mostly in primary care and not really a lot. There are fixed salaries and there is an annual allowance per patient that comes to the healthcare center. Independent midwives, they only get their money through the nomenclature or the fee for prestation, and because it's not, the system does not allow midwives to get a normal salary when they only can use the nomenclature. Almost every midwife independent midwife is choosing to also ask out of pocket extra just to get a normal salary. Legal basis for midwives in Belgium are in line with European directives. We've got a lot of laws. First of all, we have the Law of 91, where the profession of midwife is regulated, and it's really with a lot of detail what you can do, what you not can do. Qualifications to prescribe medication is since 2013, so it's a little bit like the other country I heard this morning. You can do an extra course, and when you do that, you get credentials to prescribe a range of medication concerning the child.
Now it's in the bachelor education as well.
Yeah. Okay. We have also some other laws, and we have also the law that say that we have to follow continuous education, 75 hours per 5 years. So it's every 5 years that they can check it, but they don't check it. It's only when there is a problem you have to prove that you are having done the 75 hours the last 5 years. We also have a federal board of midwives, and midwives are represented in the National Institute of Health Insurance because their voice is so important for the nomenclature, for the fee for prestation, and they can try to discuss with the other people. Yeah. Our Belgian government has a little movie on YouTube that will explain you what a midwife in Belgium does. I'm not going to read it, but something maybe it's also nice to know. In Belgium, a midwife can provide care until the age of 1 for the child. The amount of consultations is limited, but it can go up to 1 year for 1 year age.
Okay. I will continue about the education of midwifery and their professional development. So in Belgium we have a direct entry program. It's a bachelor program, and you can see the difference. In Flanders you are a midwife after 3 years and 180 credits, and in the Walloon region you have to do the 4-year program and 240 credits. In Flanders the internship is about 1/3 of the program, so 60 credits or 2,300 hours, I think. And we started a bit of debate if midwifery education should stay on this qualification level of the competency level 6, or should it move towards the 7, because there is not we do not have yet acceptance on the advanced program, so we are a bit struggling with should we have midwives at different levels, or should all midwives get that higher level. We have a lot of post-degree programs offered at the universities of applied science, so they offer also the bachelor program, and generally those programs are between 20 or 30 credits, and they focus on very different aspects, and yeah, you can choose whatever you like, or the things, the accents you want to lay in your practice. You can follow a post-degree program. 5 universities, 1 in the Walloon region and 4 in the Flemish region, offer a Master of Science in Nursing and Midwifery. So before it were more general programs, but now they really have the Nursing and Midwifery program. And 2 of those programs include really a track on advanced midwifery science. They include clinical practice, but in reality that does not guarantee you the degree is not recognized by the law. So we have advanced nurses those are accepted through law. They have their roles, they have their position, but advanced midwives roles are not taken in that debate. And that's because we split also in history. Before we had a program, first nursing and then 1 year of midwifery on top. So midwives became independent, an independent program, and now we have to fight for our own position also at the advanced level roles. However, in practice, we see the roles coming. So in service asks for those roles and they are recognized in the hospital, but their title is not recognized by the government, and so also regarding reimbursement or salary, this has some issues. It's not equal in each hospital. And it's first, of course, the university hospitals, they are starting with those roles. And I think we're about 20 midwives with a PhD, but hardly any professors. So when I look at your group of midwives researchers, we are not there yet in Belgium, but it's also growing, so we are very happy with that. Midwives in practice, so in antenatal care, there is our national guideline. And that guideline really focuses on clinical assessment, technical interventions, but also mentions prevention, vaccination, education. And so people have the freedom of where they want to follow their antenatal care. They can choose for hospital, but they can also choose for primary care in independent practice or a community health center. But there are indeed not much community health care centers that are having a midwife, because the community health centers regularly have a GP and a nurse and a physiotherapist and a social worker, but not all of them have standard midwife. This is already a bit of the answer to the first question. So here you have the figures of the proportion of low-risk pregnant women who attended at least 1 consultation with some of our healthcare professionals. And then you see that 55% of our patients in Belgium, so I speak about the country, see a midwife at least once in their pregnancy. I must say that the data is old, so I think it will, that this is data of 2016, but I don't have newer data. And so in 2016, only 0.3% of the low-risk women were exclusively followed by a midwife during their care trajectory. The median number of midwifery consultations was 2, so every woman sees 2 times during pregnancy, which is already good, we think, because we come from real low levels, and also we see an increase, and that's what we are aiming at, I think, now in care or mixed care trajectories, where midwives collaborate with obstetricians or with GPs in the follow-up of the women. And we started at 30% in 2010. In 2016 is 55% of those mixed care trajectories. And I'm very sure that if we would look at it right now, that the percentage is even higher. So we like this trend. So we are very happy with that. I also have some figures about the epidemiology in our country. So indeed, Valerie said the decrease in babies born. So she had the latest number. So we have 10,000 births less already compared to 2 years ago. And also, all other things are, of course, decreasing. We have 1% of home births or births outside the hospital. When we are looking at onset of labor, we have an induction rate about 30%, planned cesarean section rates about 10%, spontaneous labor about 60%. We have a high level of epidural analgesia use, so 75 and 80%. If you ask women in Belgium about a normal delivery or a low-risk delivery, they always take epidural anesthesia as something really normal. So for them, this is not a medical intervention. So they think it's become culturally accepted that you have this pain relief, this form of pain relief during labor. Episiotomy rates, they vary a bit along the regions. They are lowest in Brussels, 8%. 8.5, and in Flanders they are still high, 1 in 5, but also those are, the numbers are falling, thanks to Eurostat. In outcome, I think Belgium women have good outcome rates, so we have very low preterm birth, we have acceptable low birth weight rates, and I think the high birth weight rates are also, I think outcome is very good in Belgium. In postpartum care, midwives are more involved, so we see a drop of the average length of stay. In 2021, we were about 3.4 days, and we came from much higher length of stay in hospital. And the shortage of the length of stay made that midwives are more involved in antenatal care to prepare this shorter postpartum stay in hospital. And so we see a higher uptake of antenatal midwifery care, but also then in postpartum. Midwives have a role, and as Valerie said, up to 1 year postpartum, but most is concentrated in the first 6 weeks. And it focuses on, of course, on breastfeeding, but also bottle feeding, neonatal thriving, psychosocial well-being. And we screen for 18 diseases in that metabolic screening. That's also something midwives take care of. And in the period of 1 year postpartum, we collaborate also with the governmental bodies of childcare that are in all the regions present, and they give childcare up to 3 years of age, which is free for the women, so it's regionally financed, and they can get free vaccination. They follow up the growth and the development of the children, but they are rather focused on the children, also now becoming the trend towards the family, but it started from the children, so that's growing, but they are looking at the connection and the family relationships as well, because of the importance of well-being. The classic care model is still one-to-one care in Belgium. We have education sessions that are often in group, but that is not very common, or not every woman is having antenatal classes. And when we read the documentation, the national guidelines, patient safety is still the goal number 1. But in the latest antenatal care guideline, we see a shift towards the experience of women that is also becoming more predominant, and the focus towards more integrated care, especially in low-risk pregnancies. So we are happy with the shift that patient safety is, of course, important, but other things become important as well. And that they made a nice visual in which they also, this is from our latest national guideline, where they say, okay, we have the current antenatal system where everybody works on his island, and we want to go to a system where the care is more integrated, and the relation or the communication between the care providers becomes better, so we have at least information continuity of care. It might not yet be the care provider continuity of care, but that's already one step. And so we see that the government signed in 2023, the different governments, a protocol where they really say, okay, we want to move towards integrated care, where we will collaborate again between the regional and the federal government. And there are 3 programs defined, and I'm really happy to say that the perinatal care program is the first that is really launched into practice. And the Born in Belgium project is the tool that is used to implement the program across the country. And it includes a screening to psychosocial well-being, so we identify care needs beside the medical needs. It offers care pathways and connection between care providers in primary and hospital care. And so the program reimburses up to 2 additional personalized visits in case you see some issues that need more in-depth consultation. A care coordinator can be appointed and reimbursed, and also multidisciplinary consultation, because before midwives, and especially independent midwives, had to take part, or wanting to take part, for the quality of the care, but they did not get payment for all the time they invested. So that are major steps on the foreground. Of course, in the multidisciplinary consultation, other care providers are also reimbursed, luckily, but so the connection between midwives and others becomes better. We have some midwifery-led units alongside 2, one in Brussels and one in the Walloon region. The Brussels government aims to give access to the delivery wards to independent midwives, but as we hear, it's not directly implemented. They have the ambition, but there are, of course, again, legal and financing issues that need to be looked after first. And we also start to include the group care model of care, as in the Netherlands it's already standardly offered to low-risk women, I think, or it's the aim, I think, of the government, but we are still at the real beginning of that trajectory. I think we have 10 settings that offer antenatal and or postnatal group care models. They are often midwifery-led, but we also see a facilitator, duo, psychologist and a midwife, which is really lovely. People like it, and also for midwives it's very nice to do it with a psychologist. And we see also a bit, due to the problem of the salary that's rather low when you're an independent midwife, we see also that midwives become creative and a bit more commercialized in Belgium. So they offer baby massage, they offer well-being, they offer bringing together mothers, births and breakfast. They try to find things to get more activity and to get a salary, which has, of course, pros and cons. Regarding collaboration, I think our collaborator number 1 is the obstetrician, but I think midwives also collaborate with psychologists, dietitians, as I said, the body of childcare, intercultural workers, especially in hospital, GPs, social workers, pediatrician, physiotherapists, and if necessary, more specialized care. Sorry. We see that there is a difference in the collaboration network between the community-based midwives and the hospital-based midwives. Hospital-based midwives will collaborate more often with in-house people, while in community care, the hospital might be a bit more different. Independent midwives are not working alone anymore. So in Belgium, we see not an independent midwife is also often collaborating with other independent midwives to have the 24/7 continuity of care. So I think in community care, other colleague midwives are the most important collaborators, while in hospital, the main collaboration is, of course, with the obstetricians. I think this was our presentation. We can conclude maybe that Belgium has a good and safe maternity care system. Midwifery-led care and autonomy for midwives are facilitated by the legislation, but in reality, the Belgian healthcare system is still rather physician-led. That's a culture that is already since ages like that, and we have a fee-for-service system, and as mentioned this morning, this hinders and does not stimulate referral nor collaboration. So thank you for your attention.
Questions coming from the chat?
Yes. And did you also want to hear the answers on the
Oh yes.
Ah, yes.
We have them now.
Okay, great.
What do you want first? The question from the audience online or the...
Up to you.
Okay, that's up to me. Okay, I will just do the question first. We were wondering, in Belgium is fee-for-service healthcare system. Does this model create financial incentives for midwives and maybe gynecologists to perform certain procedures during childbirth?
Yes.
Yes?
Yes, for obstetricians, not for midwives. So the fee for service is totally different for obstetricians than for midwives.
Yeah. A midwife can only do the low risk pregnancy, so there is, let's say, one fee. But in obstetric care, there can be different acts during labor and pregnancy that have different codes with a different revenue.
It just works like that. Every thing you have to do has a code and generates an amount of money.
Mm-hmm.
And the more codes you can write down, the more money you can generate.
Yeah.
And for a midwife, without stereotyping, the more you also can do different consultations and you don't have to refer your patient to another level of care, the more you can also use the codes for the midwives.
Yes, okay, so for midwives it's different, but...
Yeah, you cannot accumulate codes also on the same day, for example. There are quite strict rules about the codes when you can use them. So if you would say, okay, we have a high-risk pregnancy, the woman has to be followed up by the gynecologist. On that same day she sees the gynecologist in the hospital, she might not go to the consultation with the midwife to have, for example, a longer consultation to go into depth. What is notified, that's not allowed, for example. So there are a lot of rules that hinder the collaboration between the both care providers, or even more care providers. And that is something that we hope to change.
Theoretically, there is no positive incentive for a midwife to refer to an obstetrician. Mm-hmm. So it's a negative incentive. And for the obstetrician, the more complex the situation becomes on paper, the more income he or she can generate. Mm. But that's in theory. We hope, and it's also that normally the caregiver knows when which level of care is needed.
Yes.
Yeah.
But the system does not incentive the right level of care. Always.
Yeah, there are, of course, like in other countries, I think, they are thinking about more criteria like value-based healthcare. So the ideas are coming, but it's not still in practice yet. And there are hospitals are compared between one another, so outcome measures are really showed. So patients will have access to all data that is available regarding outcome of hospital care. So I think that's also a good thing to evaluate.
Yes. Okay, yeah. Thank you. I have another question.
Yes.
It's from Nora. We heard her questions before. Who's responsible for the health of children after 1 year? Is it the general practitioner or somebody else?
Yeah, GP or pediatrician. Also there people have the choice who they go to. So yeah, that, or even if you have no really a problem in your child, only a follow-up, then you can also go to the governmental body to get your vaccination and to see if everything is going well. So,
but in Belgium, if your child of 2 has a cough, you can choose if you go to your GP or you take an appointment with a specialist.
Oh, really? So, you can choose to either primary care or for example, secondary care. Okay.
I'm here. We have 2 questions as well. First one is from Maria, and she asks, does the difference in education between regions affect chances for employment for midwives in Belgium?
Not really, I think, because the 3-year program is Flemish, so most Flemish-speaking persons will enter that program and also get a job in Flanders, while the 4-year program is in the Walloon region, so it's a French education, and French hospital hire French people. So I don't think in Brussels we have both, but like we work in the university hospital in Brussels that is financed by the Flemish government. So they need to speak Flemish in our country or in our hospital, while the other 12 hospitals, so we have 13 hospitals in Brussels only, the other 13 are French speaking, so there you need to speak French as priority and if possible also Dutch.
Yeah.
And the opposite, we prefer midwives that also speak French, of course, because the population in Brussels is very diverse.
Yes.
Yeah, but I don't think it really has an impact on the chances of a job. We have there are too many
I think
midwives.
that the situation is totally different in both sides of the country. If you see the map from the hospitals and you know that so many of the care is given in hospital, there are in the region...
the Walloon region?
Yeah, and really this region, there are not so many hospitals than in this region. So yeah, it's a difference, but it's totally different struggle in the north than in the south.
The population density is also lower. in the
less.
Yeah.
But we draw a line right here in the middle. This one is Flemish, this one is French speaking, and it's yeah. It works like that.
Yeah, but I don't think it has an impact on the chances of getting a job. That was your question.
That was the original question.
Yeah.
Okay, do we have time for one more question? Yeah. So the last question is from P. And she asked, are midwives organized on the federal or on the regional level, or both? And is the midwifery movement speaking with one voice, or are they divided in regional fractions?
Okay. I have to answer. Yeah, that is a problem indeed. On certain points there are agreements, but on other points there is no agreement, and that makes it difficult because, as we said, the entrance to the job is federal, but the education is regional. The regulations in the hospital and the reimbursement system is federal. So a lot of things are in common, but there is also a bit of different culture. And that means that we have a Flemish and a French speaking body of midwives, but also a Belgian one. And we are trying to merge, but it's not always easy, and that makes it extra difficult to make change happen because we first have to align between us before we can speak up to the government. So
we also have to go to the 9 ministries. So first we have to concentrate everything, and then back up. We also have to reach every body who's responsible.
Yeah. So you're trying,
but on topics like woman-centered care, importance of breastfeeding, shared decision making, I think on those themes and integrated care, there is consensus. But on certain things about, I can't. For example, the reimbursement of group care, we also have to first agree on that. But when there is nobody doing it yet in the Walloon region, for them, then it's not a priority, for example. And there might be other things that they already enrolled in practice and are more a priority compared to the Flemish part. But how will we then get our point at the government if we... So, of course, it makes it a bit more complex.
Yes. Yeah. So we're moving to the coffee break, but maybe the distant figures for the question.
Ja.
Finish with that.
Wacht hè. Ah nee, was dat hier. So our answer... you wanted to say how much...
the votes are?
Yes. Ja, maar de answer staat hier ergens. Yes. So the answer is the 0.3, so the less than...
0.3 of low-risk women works. Yeah, we had them in like
other categories.
Yeah,
Yeah.
like less than 10%.
it was eight people who voted that. 10 to 40% were 7, so those two were kind of similar. And then 41 to 70 were 3 people, and the more than 71 were 0. So
Okay.
nice to know.
Okay, thank you.
Yeah, thank you.
Thank you very much. So let's break for coffee and be back here sharp 3:05. Sorry? Huh? 3:05, toch?
Last two presentations, who I'm sure will also be very interesting. We go very far away now to Australia, where we will listen to Professor Alison Cummins, who is the head of midwifery at the University of Newcastle in Australia. Her research and teaching focus on equipping students for the transition to practice through research-informed curricula and structured transitional experiences. She has been the midwifery director on the board of the Australian College of Midwives and chair of the Trans-Tasman Midwifery Education Consortium. And she is an associate editor of Women and Birth International, which is a leading midwifery journal. And prior to her academic career, she spent 18 years practicing as a midwife in large tertiary referral hospitals, private hospitals, midwifery continuity of care, and private midwifery practice. So if there's one person who can tell us about Australia, it's Alison.
Thank you, and thank you for the invitation to speak. And I really learnt so much today. It's been very interesting, but lots of similarities, I think. So, this is Australia. It's huge. In an aeroplane from there to there on the way to London, it takes 5 hours. You keep looking at the little map, and you're still in Australia. So it's a big country, and there are 7 states and 2 territories, and so that is the same as Belgium, 9 health, I was thinking about this, 9 regulators of health, because each state regulates their health, each jurisdiction. In Australia, we like to acknowledge the traditional owners of the land and the custodians and recognise the land was never ceded. And this is a map of Aboriginal countries where before colonisation. The arrow's where I live, between Sydney and Newcastle. And I just want to quickly talk about the history of midwifery in Australia and acknowledge the elders past, present and emerging and 60,000 years of Aboriginal midwifery. And there's little recorded history on First Nations people's midwifery activity, but it was women's business, birth law, L-O-R-E, not L-A-W, and ceremony. And there were over 500 nations existing pre-colonisation with diverse cultural heritage. And like Canada, there is a push for Indigenous people to have a return to their traditional birthing, which is on the lands where they were born, that the mother goes back and gives birth there. So this is just an overview of what I'm going to talk about. There are education standards, and they're set by the Australian Nursing and Midwifery Accreditation Council. We are regulated by the Australian Health Practitioners Regulation Agency. Have initial registration when you first qualify, and then you have an annual, dependent on practice and ongoing education. So this is what I was going to talk about. What is the difference between a registered midwife and an endorsed midwife in Australia? That was my question. You won't have a clue, but you will by the end of the talk. So that's the idea. So we have 7.7 million people in Australia. And I've got that round the wrong way, actually. It's 7.7 million kilometres squared, right? I don't even know how big that is. 5 hours to fly out of the country. There's 27,536,874 inhabitants when I looked on the day. So that's 3.5 people per kilometre. Then we have around 300,000 births a year. And I think we all have the same average number of children, 1.5 or 1.2 or something like that. We've got 34,500 midwives, but that's nurses. It can be nurses and midwives. There's 8,283 midwife only registered, so there's 26,227 dual registered nurse and midwives. Endorsement, when you're an endorsed midwife, it's another type of registration, and we have 1,299 endorsed midwives. We don't count who works in the community, and we don't count how many work in hospitals. But there is 124.9 per 100 midwives per 100,000 head of population. and we have publicly funded hospitals, and midwives can practice in both hospital and community setting. Private midwives can have visiting rights with hospitals. So this is a collaboration. So I've got community-based midwives there because there are some, the endorsed privately practicing midwives, but there's also publicly funded home birth services from public hospitals. So with the community-based midwives, it's more just partnering with their team, their midwifery group practice, and with other midwives, obstetricians, neonatologists, neonatal nurses are out, because mostly they're women with a low-risk pregnancy, and then child and family health and the general practitioner. Whereas in the hospital, we have higher risk, so yes, they're still collaborating with the midwifery colleagues, but more likely to be collaborating with obstetricians, neonatologists, neonatal nurses. Don't have anything really to do with the child and family health nurses and practitioners in the community. Thank you. The financing is really complicated because we have a federal financing of health services, and then we have 9 states and territories who finance the hospitals and health services in their jurisdiction. All permanent residents of Australia have universal health insurance, which is called Medicare, but you can choose to have private health insurance as well. And if you don't take private health insurance, then you pay more tax. So it's an incentive to take it. Most midwives work in publicly funded hospitals. Each state has a different pay scale, and I've got that in my last slide, and I converted it to euros so you can see. So midwives' payment structure depends on their year of service, level of experience, and for example, in my state, New South Wales, midwives who provide continuity of care get their base salary. So if you're a 4th year midwife, you get that salary plus 29% to be on call. So it's a real incentive to work in continuity models. And I did write it down. The hospitals, there's 248 maternity services in Australia. Some are tertiary referral, some are secondary or primary level, and then there's level, if you're a level 2 service, you can't provide birthing. You can provide antenatal, postnatal, but if you're a level 4 service, you can provide birthing up to 36 weeks. If the woman, after 36 weeks. If she's less than 36 weeks, she has to go to another hospital. And many people in remote and rural areas get moved at 36 weeks to, like Canada, to where there's a service that can provide birthing for them. So here's the complex financing system. It's really hard to understand. So there's Medicare, right? So we all pay tax. That money goes to the government, that goes to the hospital, and that goes to the women, but they can take out insurance. So this is also, we have private maternity services. About 22% of women in Australia will choose a private obstetrician, give birth in a private hospital, and it's fee for service. So they can't do that unless they have private insurance. But 73% will go to the public system. So the woman pays the hospital, and the hospital pays the midwives. This isn't a private hospital. Then the woman claims from her private insurance money back from the insurance company, and she'll get some of it back. And also privately practicing midwives, usually that's home birth, and it's only about 1% of women. So there's 27% private hospitals, 1% private midwifery, and the rest are public. Woman pays tax, goes to the government. The government has an agreement with all the state health services and their hospitals. They invoice the government, and it's a diagnosis-related groups. If anyone knows anything about health economics, there's different models, different in every state. There's also, every state has different data collection, perinatal data collection. And then the midwife gets paid. Eventually. Publicly funded home birth, it's sort of similar. The woman pays tax, it goes to the government, it goes to the hospital. The midwife gets paid from the hospital. The woman can claim some of it on her insurance for antenatal and postnatal care for the privately practicing midwife who provide home birth. But the publicly funded home birth is all covered by Medicare. We're highly regulated, highly legislated. There's a lot of laws. All health practitioners are governed by what we call APRA, Australian Health Practitioner Regulation. There's a national law that was last updated in 2009, and each profession under APRA has their own board. So there's the Nursing and Midwifery Board, which midwifery comes under. They create the standards of practice for a midwife, and these standards are, you can see it's surrounded by woman-centred care, which is based on midwifery philosophy. But it's about promoting health and well-being, engaging in professional relationships, respectful partnerships, capability and accountability for your practice. And then there's the cross-cutting framework, things about developing a plan of care, evidence-based practice, and so on. So even our midwifery students have to be registered with APRA. And they can, if they don't practice to the correct scope, then they can be reported. And we renew our registration annually. We have to do on that the declaration of criminal history, meet English language standards, have evidence of continuing professional development, 20 hours. If you have endorsement or a notation, you have to have extra hours of professional development. And you also have to complete 450 hours of practice within the past 5 years. If you are privately practicing, you have to have your own professional indemnity insurance. If you work in a hospital, you're covered by the hospital's PI insurance. So if you want to set up a midwifery school, you need to meet these standards. These are the Australian Nursing Midwifery Accreditation Standards for Midwifery Education. There's 5 standards. I'm not going to bore you with them all, and I've just had our curriculums re-accredited, or they're under review. And you have to write your responses to all the sub-questions under the standards. But the primary thing is safety. Safety to the public, and we have, safe students. So when you go to set up your midwifery school, you have to be registered with the Tertiary Education Quality, I can't remember it, and Standards Agency called TEXA. So our university has to go through accreditation every few years in order to keep offering programs. Our programs of study need to meet the Australian qualifications framework. So a bachelor's degree is a 7. So you have to make sure that your degree matches that, and a master's is 9, that kind of thing. I don't know how many midwifery schools there are in Australia. Lots. This is a screenshot of who offers midwifery off the APRA website. There's my university. So we offer a Bachelor of Midwifery 3-year direct entry program. We also offer a Master of Midwifery for a graduate entry. But the sorts of programs offered include a double degree, nursing and midwifery, mostly in one state, Victoria. Not many others do. And the postgraduate programs for registered nurses vary across the country. There's graduate diplomas, which are 1 year. Our master's degree is 2 years. There's some of our students in the sim lab doing a water birth. So the Australian Midwifery Standardised Assessment Tool is a tool we use to assess students in our university. We do it twice a semester to make sure that they're on track, and all those are those standards I showed you, midwife standards for practice. So they have to meet those at their level. Continuous professional development I talked about, it's 20 hours, but if you're an endorsed midwife, you have to have an extra 5,000 hours of practice to apply for endorsement. You have to complete a program of study for prescribing medications for midwifery practice, and you have to do continued professional development, extra hours. And this is Belinda. Belinda's a practicing midwife in our partnering hospital who's going to come, but she couldn't come because it's a long way and it costs a lot of money and we didn't get funded. And she has completed a master's degree. So advanced roles are things like clinical midwifery educator, midwifery unit manager, clinical midwifery consultant, and navigator. That's works with very complex women, homeless women, women with drug problems, that kind of women, and navigates them through a really complicated system. Perinatal mental health midwife, lactation consultant, child and family health practitioner. So they're all kind of advanced roles. The scope of practice, you don't have to read this and I'm not going to read it, but it's, antenatal, intrapartum, up to 6 weeks. Endorsed midwives do more. They do diagnostic, ultrasound, prescribing. The Australian College of Midwives have published our guidelines for consultation and referral, and this is about collaboration. Midwives provide care for all women regardless of risk, however they need to follow these guidelines, and it's legislated in the law. So you can't go, actually, just because she's got a breech and I like her, I think I'll keep caring for her. So if she is A, low-risk pregnancy, midwifery-led care, don't have to do anything. If she's a B, it might be, I think I put some examples there. Hepatitis C, for example, is a B, so you should talk to someone about that. Whereas syphilis, positive serology, is a C. She needs a consultation with a specialist. So that's how it kind of works. We assess the woman at every visit. Is she still an A? Is she a B? Or is she a C? What do we need to do? So the collaboration is legislated. It's in all the Australian College of Midwives documents, and it's also in the Royal College of Obstetricians and Gynecologists documents. However, I just have a little example. I found a guideline online from southeastern Sydney, where I actually did work for 18 years. So this woman has got gestational diabetes, and so this is the antenatal management of her. So if her glucose levels are above target or suboptimal engagement, then review by the obstetrician, obstetric model of care. So even though they say that the collaboration happens, in practice, in this case, that woman would just go to the doctor's clinic, and that would be the end of the midwifery-led care. So I just wanted to kind of show you that. But if they're on target, she remains usual low-risk model of care. The Australian Institute of Health and Wellbeing publish annually models of care. So you can see the largest is midwife, public, then specialist obstetrician in the public system, shared care, which is often general practitioners, and I just need to quickly mention that general practitioners are funded by the federal government, hospitals are funded by the state government. So there was a big shift a few years ago to get women to have antenatal care with the GP, not to come to the hospital, because the state government didn't have to pay for it. The federal government had to pay for it. So it's really complicated cost shifting. And then midwifery privately practicing is only 2.2%, maternal fetal medicine, general practitioners, midwife private is only 0.5%. These are the 4 most common models. Midwifery group practice in public hospitals, so that's continuity of care, general practitioner, private obstetric care, that's Alex, I used to work with her. And then the most common here is the public maternity model. There are some formal agreements for privately practicing midwives to, admit their women to the public hospitals, but there's not many, and they're mostly in Queensland for some reason. Midwives' roles and responsibilities, there's codes of conduct that you practice legally, you practice safely, informed consent, shared decision-making, cultural practice, respectful relationships, and act with professional integrity and professional behaviour. Midwives have to teach, supervise and assess other midwives and doctors and conduct research in health, promote health and wellbeing. And if you don't do that, then you can get reported to APRA, and they're the regulator. So this is an example of a former midwife and registered nurse has been reprimanded and disqualified from applying for registration for a number of months for professional misconduct concerning a home birth. So a little bit of that goes on, and not a lot, but some of it. I did spend time on the council for the Nursing and Midwifery Board where we had to listen to complaints. And let me tell you, it was mostly nurses injecting things into people's faces, but there were a couple of midwife complaints, very minor, things like she changed my appointment too often. But it does say that you do need to work with women. You know, you need to work in partnership with women, which is what the midwifery philosophy from the Australian College of Midwives is. So, you know, midwife means with women and underpins our philosophy, work and relationships. And then finally, the value of a midwife. So every state has different funding, and I got too fatigued. I know that a lot of midwives are leaving New South Wales to work in Queensland because they pay better. So I thought I'd just choose those two. They don't pay that much better. The other thing is New South Wales is per week, and Queensland there is per fortnight. So it's in New South Wales, first year, newly qualified, new graduate midwife earns around 770 euros a week. Does that sound about right? Less, more? Less?
Less. Is that before tax or after tax?
That's a really good question. I think it's before.
Oh, okay.
Yeah.
That's way lower then.
We are way lower.
Yeah. That's way lower. Yeah,
That's really interesting.
4 sevens, 30,000 a year.
But it's depending how many days you
No, that's not right.
No, it's not 30,000. Or 3,000 per month.
Yeah.
No, the gross would be more. I would say.
We do get paid, so that's base rate. So we do get penalty rates for after hours, evenings, nights and weekends.
Okay.
Yeah, so Saturday is 75%. Okay, so one day you get 75% of that base rate. We get superannuation at 12%. So 12% of your salary goes into a compulsory superannuation fund. If you do that master's degree, last slide. You get more salary, and those clinical midwifery consultants, clinical midwifery educators and navigators, they all get higher money, and complicated industrial agreements in every state. And that's Newcastle.
Thank you. So, there's the questions coming from the chat. Any questions from here, from the audience? Because we didn't get time for it last time. Anybody here? Any questions from Australia?
Yeah, I have a question for you.
Yeah.
It's interesting to hear that continuity of care is financially incentivized.
Yeah.
What is meant by continuity of care in this context? How do midwives prove this in order to get paid? And how did Australia manage to get this recognized and supported financially?
The continuity of care is, the definition. One midwife, the midwife provides care to one woman through pregnancy, birth, and postnatal up to 6 weeks. And they usually work in pairs or small groups, 4 to 6 in a group. So that's the first part of the question. Now, the 29% is only in New South Wales, and it was huge lobbying, and it's only in the public hospitals. But in Queensland, I think it's higher. And it is incentivised because we have 15% of our models of care are midwifery continuity of care, so they want to increase it.
Yeah. Okay.
Yeah, and recognise that being on call is hard. Or, like you were all saying, the burnout and,
Thank you.
Okay.
That was it.
Nee, Ambrie, she's coming. We had another question, but it was
A long one.
yeah.
If I can answer it.
That's fine. Just take your time.
Okay, so the next question is from Linda, and she is intrigued by the title and description of the clinical midwife navigator.
Ah, me too.
And she has multiple questions about them. How long does this specialty exist? How many are there? And what is required to become one?
I pretty much have no idea about any of those except you need to do a higher degree. And so, for example, it might be, I'm trying to think, it might be in perinatal mental health. So you might have to do a degree in perinatal mental health, which are offered as masters and as graduate diploma courses, I think. How long they existed, I have no idea. I think Queensland was the first to do it, and I don't know when. I know where it was. It was Gold Coast University Hospital, and it was for vulnerable populations there. So, yeah, what was the other question?
What is required? How many are there? How long does it exist?
Yeah, I have no idea. We don't they don't report. They only report how many registered midwives, how many midwives and nurses and midwives and endorsed. So they don't report that.
No.
Yeah, how many there are.
Yeah.
Okay.
There are no more questions.
No more questions?
No.
Right, and the question in the beginning, do we answer that?
I have two answers.
Oh, yeah.
Not a many, but...
Do you want me to go back?
Show the question again. It's right in the beginning, of course.
Yeah. And there's animations. What is the difference between a registered midwife and an endorsed midwife in Australia?
Yeah, so one answered an endorsed midwife can prescribe medication and has more autonomy.
Yeah.
Yeah,
pretty much.
And the other one said midwife is a community and in a hospital. So a little bit more.
So registered midwives, you can still work in the community as a registered midwife or in hospital, but endorsed midwives tend to work only in community. Tend to, but they can. Again, Queensland do it really well, and I think Western Australia have some privately practicing groups. Yeah. Lillian knows Hannah Darlin, and she has was part of a private group practice. Yeah. And I was too, until, I couldn't be on call because I had to be in the classroom. So, yeah.
Thank you. Question here for Renata. You want to say your name before you ask the question?
You already did.
Because I know you were going to forget what you did last time.
Okay, so I'm Renata from the Netherlands. I know that in Australia, in some places, as a student midwife, you are obligated to have experience with continuity of care.
It's mandated actually in those standards. So in the Australian Nursing and Midwifery Accreditation Standards, in our curriculum, students have to do a minimum of 10 continuity of care experiences. And that means they had 10, and that's even for those students who do a graduate diploma over 1 year. They have to do 10 continuity, as well as all the other requirements. So yeah, it's actually it's a requirement. They can't register without it. Yeah.
And do they get paid for it?
No.
Okay.
So it's tricky.
Yeah, it could be.
I said before they've brought in this Commonwealth payment. Commonwealth means it's federally funded, not state funded. So, but not everyone's eligible. Yeah, for that.
Yeah, my name is Jolanda Newgret from the Netherlands, and I love the overview of the models of care. And you said it is recommended, or is there a policy towards how much continuity is provided, and how do you, what is it?
So all of the government documents say we need to scale up continuity of care, but currently it sits at about 15% across the country. Some places, which We haven't got time, but I did embed a link to an interactive map, and we could have seen in each state who's got the most continuity of care, but we haven't got time. Might do it tomorrow if you're interested. Yeah.
But is there a competition? Are regions called on that they don't live up to the standards, or?
No, it's voluntary. But most services want to do it because the outcomes are better. Yeah, it's cost effective. Young midwives want to work that way. Yeah.
You actually have measured that? Do you see an improvement of outcomes with continuity?
Only yes.
You do?
Yeah.
You see the better outcomes?
Yeah. Well, more spontaneous births, less likely to use analgesia, all of those things. And my research actually is for priority populations, and done 2 cohort studies with women who have perinatal mental health conditions, anxiety and depression, and found that they have all of those things. Plus, my first study found they had twice the odds, less association with preterm birth. So, because that group of women have a higher chance of having a baby born preterm. So, yeah.
Nice.
Yeah.
You see more countries.
Yeah.
More questions here. I was just thinking, because we have a little bit of time, I heard many countries talking about a shortage of midwives and attrition and burnout. I don't hear you talk about it. Do you have any of those problems?
We were just talking at the coffee break. Yes, we have all of those problems. The first thing is the universities, we are limited in the number of students that we can take. For example, 300 students apply to my university and we take 60 a year because the partnering hospitals who offer the placement say they can't have any more students. Where they do the continuity and where they do all their practice. So that's the first problem. We're probably not producing enough graduates. There's an ageing workforce. And then the other thing is, on paper, it looks like we're fully staffed. But in reality, a number of midwives might be on maternity leave, or they might be seconded to another position. So they're still marked as staff in the birth unit, but actually the birth unit, 6 of those midwives, 5 of them are on maternity leave, and 1 of them's working in another area of the hospital. So they actually haven't got enough. And there is a prediction, there's a report that was published last year, the Midwifery Futures report. There's a prediction that we're going to have a shortfall in a few years. But all our graduates get jobs, so that's a good thing.
Yes.
Yeah.
Okay. I was hoping that you were the country to show us how you deal with
No shortage at all.
And it's not the money, clearly.
No, I've just looked at the salary and I think that they're probably on par when you look at...
the penalty rate.
It sounded low, but when you... And again, it depends on whether it's before or after tax. But when you add in the other, they're actually... the first year salary on Ireland is 37,500. Something around about that.
And they probably get with the penalties, they probably get closer to 45.
27,288, but that's before any of those additional payments.
Yeah.
Which are higher Saturdays, higher weekends, higher night Tuesday.
Yeah.
And make a considerable difference.
It seems like salary is not a reason to move between countries.
I was going to take
No, interestingly, well, I mean, I was going to say, are they short of midwives? They have a lot of our midwives in Australia.
Well, when we did get short during COVID, there was a huge... During COVID, there was a shortage. There was a big attrition, and no one wanted to work in the hospitals. And after that, our state health ministers started recruiting overseas. Yeah, so we do have quite a lot. Where I used to work in southeastern Sydney, which is basically Bondi, half the staff were from the UK. Yeah.
And Ireland,
Yeah.
The other thing I wanted to say is, as part of the evaluation of our extended postpartum care, we asked staff about job satisfaction level. And it's now, the numbers are, I can't remember the actual numbers, there's no comparison between those who worked in previous service in a hospital and the extended postpartum care came out higher on everything, even higher compared to previous UK NHS. And comments coming out were, I'm working to the full scope of my practice.
Exactly.
All of them. I mean, it was always looking forward to enjoy work, would recommend it to families. Always, it was always or more up. There was no even negative or midline response.
Yeah.
All really positive.
And we see that across the world. And
Yeah.
good care for women is also good care for midwives.
Exactly. That's
Okay, I think we have to leave it at this.
Okay.
And discuss it later. Thank you. So, going to the last but not least, the Netherlands. And I don't know why I should read this from paper because I know the speech very well. Still I do. I'll wait for you to put the presentation up.
That's my French friend. That baby's about 6 now.
Thank you. So, I gladly introduce my colleagues, Anita Faber, Renate Simmeling and Jolanda Liebrechts. Anita Faber is a community midwife at the city practice here in Groningen. And before graduating as a midwife, she obtained her PhD in cell biology. Interesting combination with a midwife. And she is a board member of the maternity care network connected to the University Medical Center here in Groningen and an active member of the Mother Council of the Groningen province. Jolanda Liebrechts is a non-practicing community midwife who is currently doing her PhD on variations in the organization of integrated maternity care at our midwifery science department in the Amsterdam City University Medical Center. And in addition, she works as an advisor on the organization of maternity care at the Dutch Healthcare Institute. And finally, Renate Simmeling. She's a very experienced midwife in an Amsterdam hospital, as well as in the community. And, like Jolanda, is a PhD candidate at our department in Amsterdam. And she combines clinical practice with academic research. And her research focuses on the implementation of midwife-led continuity of care in the Netherlands. So, welcome to all three of you.
Okay, last but not least, hope everyone is still awake. So we have the honor to represent the Netherlands and tell you something about the Dutch maternity care system. Okay, so now I think at home they see the questions. So I will do it for you here. Let me see. So I have 3 questions prepared. So the first one is, what percentage of Dutch women give birth at home? And it's multiple choice. So it varies between 6% and 31%. So curious what you would guess. Do you think 6%, 10%, 14% or 31%? 31? Okay, it's 14%.
That's what I was too scared to say.
Okay, second question is, in which country do most women give birth at home? Is that in the Netherlands, in New Zealand, Canada, or the United States?
Netherlands.
In absolute numbers, you said?
Absolute numbers.
New Zealand?
Good percentage.
Sorry?
Not in percentage, but in...
No, absolute numbers.
New Zealand.
It's the United States, yes. If you look at the percentage, then the Netherlands is higher with 14%, and in the United States is 1 point something. But because the population is much bigger, then you get higher numbers. Okay, so the last question, what percentage of women receive midwife-led care in the Netherlands, full midwife-led care? Is that 27%, 30%, 34%, or 39%?
Difficult.
27?
30.
39.
It's 27%. Okay, so I will explain that later on. Okay, so let's start with the information about the Netherlands. So we have more than 18 million people in the Netherlands, a very high population density, with 166,000 births per year and 1.43 births per woman. There are no reliable data on the midwives working in community or in the hospitals, so this is an informed estimate. What we see here, about 2/3 of the midwives work in the community and 1/3 works in the hospital. We have 69 hospital organizations in the Netherlands. Not in all hospitals you are able to give birth as a woman. Not all hospitals have maternity services. And some hospitals have multiple locations, but then you are not able to give birth there. Some hospitals have the clinic for the prenatal care. On the map, you see the travel time it takes to get to a hospital. As you see in minutes, as you see, it's very low, except for the islands on the upper side of the Netherlands. And we have 8 medical centers, academical medical centers, for the high complex cases, and also the academic research. Our system has a formal division between primary midwife-led care and secondary obstetrician-led care. And you see here that community midwives collaborate daily with a wide range of professionals, where hospital-based midwives typically work closely with a small, more defined group of colleagues and have limited interactions with others. So it's more divided. And here you see that for community midwives, it's daily practice. Okay, so the financial system for the hospital-based midwives, well, all people in the Netherlands pay taxes, and you are legally required to have an insurance. So that money goes to the government and the insurance company, and the government pays the insurance company as well. And then a hospital has a formal agreement about the amount of care they are going to provide, and that's going to be paid. And that's so hospitals are reimbursed in diagnosis treatment combinations. So it's like an episode-based bundled payment. So you can compare it to a fee-for-service system, but it's grouped into care episodes. And for the community, the first part is the same, but community midwives provide care at home, so they are there for a home delivery, but also in birth clinics or in a hospital. So you are able, as a woman without a medical indication, to give birth in a hospital with your own midwife. If you do so, then the woman needs to pay for it out of pocket. She needs to pay a fee for that. And the same applies for maternity care assistants. Here in the Netherlands, we have maternity care assistants who provide care at home after birth until approximately 8 days postpartum. And a woman needs to pay a certain amount herself. And The hospitals have an agreement with insurance companies, but midwifery practices or the midwives, they send an invoice, so they are paid for the care they are provided. That is provided. Maternity care is publicly financed, and community midwives, as I said, are compensated per care episode. It's divided in pregnancy, the natal care, and the postpartum care. And it's based on the care they provide. So there's no division in based on experience of the midwives. There are 8 regions in the Netherlands that have bundled payments, aiming to stimulate more integrated care. The core value here in the Netherlands is that pregnancy and birth are healthy physiological life events, so not medical complications. So community midwives are independent primary care professionals legally authorized to provide full antenatal, intrapartum and postnatal care for low-risk women, and they are legally gatekeepers to specialized care. Their scope of practice is also legally in the Dutch Individual Healthcare Professions Act that protects also the name midwife. So if you didn't do the education, then you cannot call yourself a midwife. They have prescription rights for certain medication and also are authorized to perform specific procedures. And they provide midwife-led care. Hospital-based midwives work in obstetric-led care teams, and they provide antenatal, intrapartum and postnatal care for women with higher risks or with complications. And it varies a little bit per hospital if all midwives provide antenatal care or only intrapartum care. So they focus on physiological care in a medicalized setting. And they collaborate closely, as I showed with dots, with obstetricians and nurses, and in some hospitals also residents and also maternity care assistants. They are registered under the same legal framework and they have the same education standards as the community midwives. In some hospitals, it's an option to do a master's degree. Some hospitals pay for a physician assistant master, but you can also choose for a different kind of master outside of midwifery. This year, there's a new national quality register launched, which was formed in collaboration with the organization of obstetricians as well as the Dutch organization of midwives. It formally recognizes the expertise and specific role of the midwife in obstetric-led care. If you look at education possibilities, it's a direct entry bachelor's program of 4 years, and then you get your license to practice as a midwife. There's an option for a master in midwifery. I think it started in 2023, the master in midwifery. It's non-mandatory, so you can choose to do it, but as I said, you can also choose to go for another master, like evidence-based practice or something. There are slightly over 50 midwives with a PhD, and we have 3 professors in midwifery. You are also expected to continue your education as a midwife. So we have a national quality register from the Royal Dutch Organization of Midwives called the KNOV. It ensures that midwives maintain high professional standards. So registration demonstrates completion of formal midwifery education, continuous education, and sufficient experience, and also recognizes certain specializations like external cephalic version or the counseling for prenatal screening or ultrasound. This is related to the question that I asked, so how many women receive full midwife-led care? Here in these figures you see the purple is midwife-led care. So the primary midwife provides care, sometimes with a consultation if necessary, but she's still responsible for the care provided. And the gray are referrals to obstetric-led care. And the only thing missing here is that all women postpartum return to their community midwife. So 100% receives care after their birth in a community. So you see that there's no real continuity of care. That's also the focus of my research. As Ank said, my research focuses on the implementation of continuity of care, which we do in 3 levels. So we want in a community that a woman sees only 1 or 2, or at least as possible, midwives during pregnancy, birth and postpartum. But also we're looking at shifting care back to the community because there is an increase in referrals and we want to decrease that again. And we want to reach full continuity in the end. Here you see that the officialization of the role of the community midwife. This is a network of maternity care professionals, and you see all the ties. And in the left, you see around 40 or 4,000 ties in the network. So that shows the collaboration in the network. And in the right, the midwife is left out. And there you see half of ties. So you see approximately 2,000 ties. So you see that the community midwife is the lead professional in collaboration. And then it's up to Yolanda.
Thank you. You said already a lot. I want to say something about the maternity care models, also relating to the different levels of care. It's kind of the, what is it, the samenvatting? Summary, thank you. It's late. Of what Renate already said. So we see that we have community midwives in midwife-led models on the micro level, and we have hospital-based midwives. The meso level, the regional level, I will speak more about it. It is an important level in the Netherlands. And the macro level, as we already said, we make national guidelines. There is national policy, integrated care. We have an integrated care standard, but there is a lot of freedom to translate that to practice. So in national guidelines, for example, we see that they are multidisciplinary made. In every region can translate it to specific regional context. And ultimately in practice, there's a lot of still space for healthcare professionals to carry out in the width of what they can do in the guidelines. On models, for example, caseload models, midwifery group care, in antenatal group care or group practices, midwives have a lot of freedom how they will organize their care. And on a regional level, as Renate already said, we have 69 hospitals with 68 regional networks, maternity care networks, where the professionals collaborate to organize the care. And in these collaborations, they can decide where they will put the emphasis. Will they want to put more continuity of care? Do they want to establish group care, maybe a multidisciplinary ultrasound system center, birth center? So there's a lot of variation in the organization of care. Already named, our professional body plays an important role on a national level to influence policy and guidelines.
And I put a chief midwife at a macro level because we don't have one yet, but we really envy the countries that already have, and I know that the professional body is looking at in which form and how we could organize that too. And to say a little more about the collaboration, and I want to focus on the regional level, where the obstetrician, the community midwife, hospital-based midwife, maternity care assistants, youth workers, all centered around clients have to organize that care. But that collaboration is a complex system in itself. As I said, it is guided by protocols and work agreements, but highly influenced by trust, by power dynamics in that region, and by whether or not these professions can reach a shared vision. The collaboration highly depends on available time and resources, as all the professionals have to add time above their clinical practice to work groups, guideline developments, and other organization in the region. But that collaboration influences the organization. So if that collaboration and they reach a shared vision, they can also generate a lot of energy to organize their networks. Client participation varies highly in between in between the regions. So we all say we want to center the client, but the client not everywhere has a steady seat at the table. And the position of midwives really varies. So all the community midwives of every of the 68 regions, community midwives have a seat at the table where the decisions are made. Hospital midwives depends on the agreements made in the hospital. But how they influence decision making varies a lot. And that is something that I think needs some more attention on all levels, so also on a national level. That was the overview we could give you in this short amount of time on the Dutch way of organizing. So we are open to questions.
Thank you. Are there any questions here before we see if there are any See no fingers here, so you first?
We are first.
What did the people online think about all this?
Okay, so we have 3 questions in total. So the first question is, what are the experiences with the bundled paid regions compared to the other forms of payment? Do you have some answers on that?
The question is, what is meant by experiences?
Yes, so do you see how do the midwives, do you see any differences? How do you find these other forms of payment?
It depends. As we said, we have 8 bundle payment regions, 2 of which attend in my study. I researched 7 regions, of which 2 who have a bundle payment. And there is a huge variation in how bundle payment is carried out in these regions and how they are experienced. So we have regions where where midwives really embrace it and feel a lot of empowerment and freedom to actually organize care. And with a bundle payment, you also can generate shared savings. So if you organize differently, you also have money to invest in further development. So that brings energy. And there are regions where they started bundle payment and in the end stopped bundle payment because it caused a lot of friction, it caused a lot of division in a region. So it is a means to an end, it is not an end.
That's a very good answer. The other question is, maybe for you both, in 10 years' time, do you think there are still home births after seeing the percentages decline?
Maybe even more.
Yeah, what do you...
I think so, because what you see is that women ask for it. So as long as women are satisfied with the care that midwives provide, I think they will keep on asking for it. So I think it will still exist, yes. Okay. But I think, sorry, I forgot to mention that in the Netherlands, for a full-time midwife, we have 106.6 full courses of care.
Yeah.
And to be able to provide continuity of care, it must be lower.
Yeah, maybe take some inspiration from other countries, like 40.
Exactly.
Yep.
Yeah.
Okay, we have another question. It's a short question, but maybe a large answer. What is your vision for the future of midwifery care?
Final question. You can go back to the first presentation we had this morning, which showed that there must be aandacht. Attention, sorry.
You're such a good duo.
Must be more focus on prevention. So if we focus more on prevention, then in the end it pays us back.
So your vision is paying more attention to prevention?
Yes, because midwifery is an ultimate form of preventive care.
I have a slightly longer answer, I guess, but as Ank said in the introductions, I'm full-time working on my PhD, and I have a small amount of my time I can work in the Dutch government advising on what organization of care should look like. Will we make it more sustainable? And only maternity care is a small part of it, as the keynote in the morning already said. But I truly believe that the key in this transition lies with midwives. But that also requires taking your position, know where you are from, and put it at the table and lead that change. So the future of midwifery means that midwives are more standing beside women in a community, guiding them through pregnancy and childbirth in collaboration with other healthcare professionals, not only obstetricians, but also in the community, also to support the living circumstances, social economic circumstances. So it broadens maybe the scope and influence, but I think in the transition they play a key role.
Because of? Why would you play a key role?
Because they are already there. So you have a holistic view, a preventive view, an incentive to work for women's well-being. As we heard in the morning, that's exactly what is needed. But these voices are not always heard yet.
Thank you. That was the questions from online. Yep. Did any more come up here? We have listened to the discussion. Alison?
Thank you. It's great to hear the overview, and I thought you had more continuity, personally. That's my belief here. But the chief midwife. So in Queensland, they've appointed one. Queenslanders, but New South Wales government have just committed to appointing a chief midwife for our state, but not nationally, not for Australia. It's a chief nurse and midwife, and she's not a midwife. She speaks on behalf of midwifery when she's a nurse. So I think having that seat at the table, right at that level, is really important. Yeah.
I think so too. Yeah.
Can you repeat it for the audience?
Oh, yes.
Oh, I'm sorry.
Because otherwise the online participants cannot hear what's going on.
So from Australia, you say like the chief midwife is established on a regional level in two. It is not called a region, and you said it. State. Yeah. So on a state level, one was already earlier established, and another one is now established, but
announced to be established.
Announced to be
Position
established.
is not advertised yet, but not nationally, which
No.
is where it should be. There's a nurse who represents midwifery.
Yeah, so it is in two states in Australia, or in one it is established, in another is announced to be established, not at a national, federal level. And the person who is in this position represents nurses and midwives, and the one who is at the table is a nurse advocating, also have to voice for midwifery, and that is not ideal, as you said. Like, it should be a midwife advocating for midwifery.
Thank you, Sid.
Anyone else? We have time. We're actually well out of time as well. Any more questions? Are we all sort of ready to get through the drink? To get to a drink now after a long day. Oh, thank you. It was all clear then. Thank you very much. So, I don't know about you, but for me the day went very fast. It was extremely interesting. And now I've been asked to summarize this. I don't know how, to be honest.
You can do it.
Oh, goodness. So forgive me in advance. I'm sure I forget some important things. What I do is I briefly mention what I remembered as main points from each presentation, and then maybe summarize some key points that I think came up through all the presentations. And maybe we then have time to discuss it a little bit, if you're still up to it after this long day. So we started this morning, seems like a long time ago, with Cornelis Broersen. And it was a bit more far away from midwifery maybe, but still very relevant. And he was talking about the problems we have in healthcare generally, with, I think in all our countries, increasing costs, decrease in personnel, in staff. We're doing well on reducing mortality, but not that we live healthy much longer, so we have an increase in morbidity. But he's quite an optimistic person because he said we should turn the problem into an opportunity, always like that, and that would result in innovation. And one of the key things for innovation, as Jolanda mentions, is increased prevention, the focus on prevention, which in percentages seems to increase, in our country at least, but in absolute money going there is still very small, so we have a lot to do there. And he argues that instead of paying for the things we do, that we do now in most countries, we should actually maybe pay for outcomes. And those outcomes should include the environment more and more as well. And he also mentioned that instead of measuring what people are willing to pay, we should ask them what are they willing to invest for the future. And one key thing in all that is a change in payment models. The payment models currently, and I think I heard it in many countries, is not encouraging the changes we need to see in healthcare. Now, he said many other things, but this is what I remembered. Then we went to Ireland, Deirdre Daly and Nora Vallejo, although Nora was with us online. There we heard the system is mainly hospital-based, that there are different grades of midwives, so you have a kind of a career structure, that there are midwives working in the hospitals and in the community service. There are some midwife-led clinics, not that many. And Deirdre talked a lot about postnatal care and how that was extended, first in some pilots and now hopefully much further, how that helped improve care for women, but also for midwives, as you just said. That actually showed very much that you have to persevere when you want to make changes, because you started with this a very long time ago. And sometimes you think you're not getting anywhere, but eventually things change. So that, I think, is a lesson for us all. Your care is divided in supported care, assisted care, and specialist care. And although your strategic priorities say that the care should be woman-centered and focus on normal physiological care, the practice is somewhat different sometimes, as always, the difference between theory and practice. Now, then we went to Canada, Megan Furnival and Beth Murray Davis. One thing that made us all very jealous is your high rates of continuity of care. It's fantastic. I think this is how we all want to practice midwifery. However, it comes at a cost, because we only have one type of midwife who's basically working in the community. Now there are very few hospital-integrated midwives, but that means either you're a midwife or you're not. So people who can't do the full scope then give up, and then we lose very experienced, maybe valuable midwives. So that's an issue. Because it means you have to do at least 12 weeks of care, I understood, and the birth to get paid. So you can't do less than that. You also have to do quite a lot, 40 births a year, but also 40 births as a second midwife. So sustainability is an issue, like in other countries, but also in Canada. You do have some sort of career structure with 6 levels of midwives, but in the long run, it's not going to make the difference because you be for a long time at the 6th level. Yeah, and in terms of continuity, 93% of midwives, of women in midwife-led care, know their midwife at birth, something to be very jealous of. And you are seeing an increase in vaginal birth with this type of care. And you actually have a very low transfer rate. Well, definitely in terms of compared to Holland, Dutch rates, but I think generally, so that's very good. Okay, that was. Then we moved to Germany. We listened to Nicola Bauer and Anna Brodersen, and they told us a lot about midwives, but actually don't know how many there are or where they are. So that's interesting. That was an interesting take-home message. But you think the majority are in the community, I think. Some are both in the community and in hospital. And what's an interesting bit of German legislation that every birth should be attended by a midwife. And an obstetrician is not always necessary, only if there's a risk. But in practice, of course, he or she is often there, given the powers at play. I also found it very interesting, you said a little bit about how you're trying to change the finance so that you're not paid per episode but per time, which actually feeds back to the first presentation we had. So maybe there's some lessons to be learned from you, how to do that. Also interesting how Germany really, since 2020, is aiming for a full academization of midwives. Unfortunately, at the moment, you don't have enough midwives to even fill academic posts. So obstetricians fill them, also interesting. So we have a bit of work to do there. And you have freelance midwives, and some of them are in hospital too. Good. Then we went to Norway. I hope I have the sequence well. Yeah. We went to Norway, to Hilde Christensen and Enid Murja. They started with a very sad story that we all recognize, I suppose, but it's quite touching, I think. It's newspaper publication about such a shortage of staff, midwives and other staff, and how that's really affecting quality of care, but also well-being of staff who then, leave at an increasing rate. So that's a real issue. I think midwives work in hospital and the community. There's not many home births, and home births are paid by women on the whole. Although the health insurances now sometimes can pay, they often choose not to. Midwives have an independent responsibility for risk selection. So that's one of the things I said this morning, that sometimes we think we are very unique in the Netherlands, but there are other systems that work in a similar way, at least in some of the areas of care. Postnatal visits, women are entitled to having a midwife visit them, I think 1 to 2 days after birth, but it doesn't always happen because of the shortage of staff. You do have continuity though in antenatal care and in postnatal care. And you cover a large area of care of women's health, also including contraception, which raised the question, is your scope of practice not too large? But that's something we could discuss. And also in your country, although it's known for a low number of cesareans, you see an increase in medicalization of birth. There are some pilots on caseload care, which is interesting. However, I also think I heard you say there's a decrease in midwife-led units. So that's a bit of a pity. And the leadership positions, I was surprised, are mainly taken by public health nurses, not midwives. Some work to do there too, if we talk about capacity building. Okay, then we went to Belgium. Many hospitals. Well, you've got many of everything. You've got many hospitals, you've got many ministries of health, 9. In I think the smallest country at the table here. I don't know how you do that. 2 associations of midwifery, 3 levels of decision making. I think you're doing a great job to give any care at all with this. But most midwives work in the hospital, some in the community as well, and some in both. And midwives can actually give care up to 1 year after birth. That's also surprised me. You have 5 master programs. You've got many midwifery academies too. And 5 offer a master's program. 20 midwives already have a PhD, which is quite a large number, I think, for a small country. Women can choose private care as well. And I think surprising to all of us, only 50% of women see a midwife and only 0.3% see a midwife throughout. So some work to do there as well, maybe. Interesting is that from a policy level, the experience of women is becoming more important. So that's hopeful. And now to see how you put this into practice. And you are experimenting with alternatives like midwife-led care and group care. So that's interesting too. Then, Australia. Alison Cummins. You have a very complicated finance structure. I can't rehearse it all. But something with private, insurance, out-of-pocket payments. So it's very complicated. 27% also have private care in hospital, only 1% by private care midwives, that's mainly home births. We learned about endorsed midwives, it was new to us all, and that means midwives who do something extra, or maybe experts in mental health or something like that, and then have to do extra hours of training and show a minimum hours of practice as well. You led us through all the legislation and accreditation bodies that are all national, although many things are also organized at state level. You have, like we have, clear guidelines for referral. Often here in Holland we think that we have guidelines for referral as a Dutch thing, but it's definitely not. You've got exactly the same system as we have. Although you said, well, the B, we also have the B, which is collaboration, often means the obstetrician takes over. I think we see that here too. The midwifery philosophy is beautiful in that it says you have to work in partnership with women, and you also show that maybe we can do that a lot more than we do, maybe sometimes. The pay scales even came along that even vary a bit by state. And very interesting, and some questions were asked about that you actually from policy level encourage continuity of care. So that is fantastic, and also because you see that it has better outcomes. Now, I think we can all learn from that and see how you got that at policy level. We want that too. Okay, finally the Netherlands. Now, I think some people were even more pessimistic about the home birth rate than it actually is. But it is lower than many people think in the world. It's actually been stable very much for the past 10 years, so hopefully it doesn't go much further, down much further. So the system is publicly funded, and quite separate levels between hospital-based obstetrician-led care and primary care community midwifery. In some regions, we're experimenting with bundled payments. So some seem to have good outcomes, some are struggling, like Yolanda was explaining. So we still have to see which way that is going. Midwives who work in the community work like independent practitioners and actually gatekeepers to specialist care. Maybe that's a bit unique to our country. You don't see that often. Actually, women start with a midwife, and only if they have risks, they go to obstetrician-led care. However, I think Renate showed that we also have many referrals to obstetrician-led care. So that means, as you said, Alison, there's not as much continuity as you would think. So, yeah, we can do better there, I think. Hospital midwives work in obstetrician-led care, and increasingly, luckily, there's more legislation to give them also the position that, or a recognition for the position they have, so that's good. I thought did I say here? But Renate showed that the community midwives are actually a key player if you look at the networks of care around maternal and child health. So she has a contact with almost all the partners in the chain of care. Yolanda showed that there are national guidelines, but there's also a lot of difference in interpretation in regional levels. You have a lot of regional variation, including how much clients are involved or not. And the collaboration depends a lot on trust and time and that sort of thing. Now, I hope nobody feels that I've overlooked very important issues. I just thought I'll summarize a few things that I saw in all these talks, and maybe I think we may still have time for a little bit of discussion. We'll go ahead of time. Generally, what I heard is, well, one that came out in many presentations, capacity, shortage of midwives, affecting quality of care, but also the well-being of midwives, and that's a real issue. And I think in our discussions we could learn maybe what we could do about that. Scope of practice is another one. It varies quite a bit between countries what the scope of practice is. Also, it varies what is the scope of practice for midwives on paper and what happens in practice. whether midwives are allowed to work to the full scope of practice or are taking also maybe the space to work to the full scope of practice. So a lot of things to do there. Education varies a bit, but you see generally, I think, in many countries that education is upgraded. And also it's nice to see more and more academic level of education after bachelor, many master programs, PhDs, and I think we need that sort of capacity building too if we want to make the changes we want to see. Then we need to improve things, we need to change things and really work on woman-centered care, which, as Renate says, is also prevention, promotion, health promotion. So we have to change from acute care to more prevention, and that's not easy. And to go back to the first presentation again, for that we need a change in payment models. Now, we learned from Ireland that you can change these things, system things, if you have a lot of patience and perseverance, so we shouldn't give up. And also we learned, I think also from Ireland and from many other initiatives, I think, that key in this is a collaboration with clients. If clients want things, then I think it's the key to change, and also it's why we do it, isn't it? So that's what I got out of it, but I would like to hear your reaction, and if I forgot things, or are there things you agree with or you want to discuss? I think we have some time for that. That'll be great, actually. And thank you all very much for giving the forgot to say, well, I'll say that at the end, but thank you very much for the fantastic presentations we had and all the questions that were asked also and the interactions we had. And maybe we can have a bit more discussion on this. So, please, react.
I want to say congratulations to you for a beautiful summation. I think you're one of the few people that could do it, and Fiona. I would like to say a huge thank you to Esther and Lisbeth. That's not what I was saying to you when Nora and I were preparing the presentation, because it was so challenging. But we have all reaped the rewards today, I think, so a huge thank you for your foresight. I've been around a long time, but this has been extraordinary in terms of drilling down. Do any of you remember years ago, probably decades ago, Marianne Mead from the European Midwives Association? She was UK-based midwife. She was in the European Midwives Association, but she published papers on midwifery in Europe. And all of that, and a snapshot of that. Nothing was at this level, which was fantastic, so thank you.
Thank you for your summary. I think it's you met in German. You say you hit the nail on the head.
Yeah, we say that too in Holland. Thank you.
And I was just thinking on your last topic. If the client wants change, it will be a very strong push. I think one step back, we have to ask the clients the right questions. So as you were saying, Deirdre, sometimes you have the evaluation. How was the food in the hospitals? And was the bed comfy? But we need to ask the right questions to get the wishes or the perceptions of our clients to change something.
Let me explain, because I keep forgetting, but I have to summarize it for people online. We shouldn't forget them.
Okay, sorry.
So you're actually saying, when we talk about we need the clients to bring about change, you are saying we should also ask the right questions. We ask them peripheral questions like, how was your bed and the food? But we should ask them, what did you really think of the care? What is important to you? Did I summarize that well? Yeah.
Yeah, and also
agreed.
Thank you for the invitation and this great group, and it's great to exchange and talk, and I'm happy to be here.
So many thank yous here from Deirdre, from Nicola for the organization, rightly so, for Esther and Lisbeth organizing this and coming up with this topic and bringing us together, and the great discussions we had.
Thanks for the audience online.
Thanks for the audience online. I hear here too, yes. They've been very active. You've been very active too. Yeah, excellent. Anything else? So what are we going to do differently tomorrow?
I believe you have to work more.
Yes. Oh yeah, that's true. That's true. We have the people here in the room are going to do some work tomorrow. Yeah, that's true. Day after then, or next week. What are we going to do differently at work? What has inspired us? Yolanda.
I was really inspired by how they have a good data system in Australia and look at which models of care are where, how are they connected to outcomes and also to inform policy. And I think that is an inspiration, because I forgot to say when I was talking about organization in the Netherlands, we do have perinatal data, but we do not have regional quality measurements or how we can compare one another. So that is what it really inspired me, and I think is important in moving this forward.
Yeah, it's not an easy thing to change. Yolanda is inspired by the data from Australia. They even have data at state level on quality of care, going beyond mortality and morbidity, I think. That can inspire policy. And models of information on models of care. So we want that too, but that's not easy to change next week. I think it takes a bit longer. But you have to start somewhere. That's true. It's an ambition.
How do you collect the data in Australia? Do you tick a box, I'm doing this model, or how do you collect the data?
There is a paper published, so it's Natasha Donnelly's paper. So she made a classification system to start with. So you've got to classify what the model is and define it. So that was the first thing. And then the government surveys maternity service providers because they fund them. So they have the right to ask them what models they're offering, is my understanding. But it is published in the paper, and I can send the link to
Fantastic. So you've said Natasha Donnelly published the paper on first how you define maternity models?
Classification system for models of care in Australia.
How you classify maternity care systems in Australia, and then the government made it compulsory. You tick the box as a provider what models you are offering. Okay, well, that's something we should maybe try to get in other countries as well.
Yes.
Lilian? Oh, you're just going through your hair.
I was inspired by the presentation from Ireland, the fact of telling again and again and again and again the same thing, and to let women speak about the topic. It's so simple, but often the most simple acts are the best.
Yes, so I hear the inspiration from Ireland about showing things again and again through the mummy study, showing the same surveys, same messages, but also to let women speak. I think here too we have no clients. We should have thought of it maybe, but we often forget them. And they can be so powerful in telling their story and maybe telling policymakers too what they think.
Could I comment on that? It wasn't particularly inspirational of me to do that when I set up the mummy study. The reason I did it is because I was a midwife. And it was the way I practiced. So it was my practice that influenced my approach to research. And if that's what our values and philosophy says, then every one of us, no matter where we are, in research and practice or in publication, should be in partnership with women. That's my simple understanding of it.
Yes, so I'm just repeating. So you were inspired by women because you were practicing midwife at the time. And that's what inspired you to set up the mummy study, and you're saying that well, wherever we are in practice, research, education, we should collaborate with women. It's so crucial. And we always say we do, but we often forget them at the table when we really do things. Yeah, that's true. Very good. Anything else?
Yeah, I want to... what I hear today, I think overall it's very important that there are midwife leaders and they dare to speak up, because when we don't speak up there we get nowhere. And that's amazing that here are many midwife leaders at the table that did fantastic things and it's very inspiring.
Yeah, thank you. So you're saying what you see is we need midwifery leaders who also dare to speak up, to change things. It's all very well blaming the outside world, finances, obstetricians, everything else. But it's also, we have to take the position that we think we are entitled to for the sake of women, then we also have to do it. And we have to train colleagues, I would say. I will add to that. Yeah, we have to... Deirdre and I were talking about how we also have to do capacity building and make sure we have all the cadres of midwives in education, research, practice to bring about these changes. Yeah, very good point. I think we're coming to a close. I can see that people need a bit of rest and work again tomorrow. So let me also say thank you very much, Esther and Lisbeth. Thank you, Relinde, sitting at the back there. When things went so smoothly, you don't realize what happens behind the scenes. A lot of sweating and things going on, but Relinde made sure it all went very smooth. Thank you. Thank you for everybody online, indeed, for your active participation. It's always much more fun to be here live, but it's not always possible, so thank you so much. The moderators, yes. I don't know if they're... Let them come here, then we can see them. Oh, well, we've all seen them because they came to the front, so yeah, we couldn't have done it without them. Am I forgetting anybody else? You people in the room, thank you too. And sorry?
Tomorrow we go on.
Tomorrow we continue and have a very pleasant evening. Enjoy Groningen and see you tomorrow. Bye-bye.